discussion.
Make it change from the class. Start the question, make it class. Make a list point, sir.
Hi, I'm Dr. Buddhika, oncosurgeon from Ratnapura. So we have 5 panelists, expert panelists for the discussion. Dr. Dilip Mahaliyana, he's a consultant oncosurgeon from Teaching Hospital Karapitiya, and Dr. Nalinda Munasinghe, consultant general surgeon, specialized in breast, and Dr. Priyanka Abegunasekara, consultant histopathologist, and Professor Udari Liyanage, consultant radiologist, and Dr. Mahilal Vijay Korn, consultant oncologist. We'll welcome you for the panel discussion. So we'll be having 7 cases to be discussed today. I'll be asking questions from the panel. And if you all have questions at the end of the each case, you all also can ask questions from the panel, right? So we'll start with the first case. Yeah, okay. So this is a 45-year-old school teacher presented to the breast clinic with a lump over the right breast. On examination, she had 2.5 into 2.5 centimeter lump over the 9 o'clock portion of the right breast, and axilla is clinically negative. She is otherwise healthy and she has no family history of breast cancer. So my first question is from the surgeons. So how would you start investigating this patient?
As for any other breast symptom, usually the triple assessment is the standard procedure of investigation in these patients. So you have to do a thorough physical and physical examination as well as the history in detail. Then followed by imaging, including mammogram and ultrasound scan. Then depending on findings, then we have to go for when there's lump, of course, for the cytology or the histology, but the histology is preferred in current situation.
Yeah, so as Dr. Dilip said, so we are starting with the mammogram. So this is the mammogram film of the patient. Dr. Udari, how would you describe this lesion?
Yeah, so basically, this is the right side mammogram of this patient, and you can see the CC and the MLO waves, and there's an obvious lesion. You can see the breast density is quite scattered, right? So you see very clearly the lesion that which is corresponding to the clinical lump. It was at 9 o'clock portion, right? Yeah. So this is, you look at the MLO, it's more retroareolar, but on the CC view, you can see that it is also very close to the nipple and the areola in this line, but a little bit on outer side. So like it'll be, and also it is several centimeters, it will be several centimeters away from the nipples and very close to the chest wall. So that's where this, so it is the lesion that you're talking about. And it is quite dense, right? And irregular in shape and with speculated outline. And you can see there is some perilesional architectural distortion. So this is a typical malignant BI-RADS 5 mass.
Dr. Udari, how reliable is the mammogram for lymph nodes?
Yeah, so mammogram shows lymph nodes, but the best method to see lymph nodes out of the 2 investigations that we did is ultrasound. Overall ultrasound is much better because on mammogram, here the axilla is partially imaged because I think we have cropped it off when we tried to get the name off.
Yeah.
So you do see lymph nodes. On mammogram, you can see the size of the lymph node. You can see the fatty hilum and the cortex, but we don't go into that extent on mammography unless they are very, very large and dense and round. On ultrasound, you will see a lot of information. You see the anatomy of the lymph node, you see the shape, you see the hilum, the cortex. We measure the cortical thickness, the vascularity on the hilum, and whether the vascularity is there on the periphery. So we go by the cortical thickness mostly, and the whether the cortical thickness is diffuse, smooth. About 3 millimeters is taken as normal. So for especially focal cortical thickening or absence of the fatty hilum, that's the other thing. Hilum we can see on ultrasound. We don't have an image to show you, but it's echogenic and you can see the hilum. It gets smaller and compressed, and sometimes it disappears in obviously very highly suspicious nodes. So ultrasound is the
best.
the best.
Thank you. So, So what are the typical mammographic, you have already mentioned few, what are the typical mammographic features of a breast
So
malignancy?
the mammographic, when you talk about mammographic features, there are a number of few main features. The main abnormality that can appear is a mass. That is what we usually see, a mass. Usually what we expect to see. But other than the mass, malignancy can appear as an architectural distortion without a mass, or just suspicious. Yeah. All right. Okay. That's thank you. So a mass or a asymmetric density, microcalcifications, or an architectural distortion. Those are the four main things that the malignancy can appear as, but mass is the most common thing that we see. So I just described the mass. So I think we will go into microcalcifications and others later, right? Yeah. Okay.
Right. So, Professor Dar, what are the different views you are taking when you're doing mammography?
So what we saw was the standard 2 views. So there are 2 breasts. So we image both breasts in a standard study, and each breast has 2 views. If you go back to the image. So this is the craniocaudal CC compression, where you compress the breast like that, craniocaudally. So the other view is, this is the MLO view. It's medial lateral compression, but not direct medial lateral. It's an oblique to catch the axilla. So that's why it's MLO, medial lateral oblique view. So these are the 2 standard views. So you have 4 images from a standard 2D mammography, the 4 views. And I saw something about expression, compression view, right?
Yes.
So like when we do the standard views and then we start reporting that we see sometimes probable abnormalities, so areas which are concerning, which are not very clear. Because one of the main issues of mammography is overlapping. The breast is a 3D structure, but the mammogram is 2D, right? So to overcome, when we compress, so everything, there are overlapping shadows. Sometimes now this breast, the mammogram was quite clear because it's scattered fibrogranule density, quite more fat than breast fibrogranule densities. But sometimes when the breast is dense, especially, it's very difficult to identify whether actually there is a normality or it is a summated, made up shadow. And sometimes you think there are microcalcifications very faintly, but you can't really see them. In such situations, we do additional views, and there are a number of additional views. One of the commonest is a compression view. They are the paddle now. To take this mammogram, you use the normal paddle, which can compress both breasts. But on a compression view, there are special paddles like, oval-shaped, round, square shape. Those are you identify a particular area, the mammogram on the breast, and correlate that to the breast, and then compress, specifically compress that area and take a compression view. And we can combine magnification also to that we do on when we image for microcalcifications. And I have to add, now there is this thing called tomography, which is available in, I think, in government sector. It is there, no? Yeah, tomography. So tomography is, now this is a 2D mammogram, right? So tomography is called 3D mammography. So in tomograms means cross sections. Okay. So in tomograms, what happens is we compress the breast, same views, but different machine hardware and software. We do cross section, thin cross sections of the breast. These are called tomograms. So we can go up to 1 millimeter thickness. So there are so many measures there. So we don't print them. We look at them on the workstation. That takes away that overlapping element. So when we combine 3D mammography or tomography to 2D, that doubles the dose of radiation, but increases the chance of calling them back, record mammograms, compression views, and helps, quite helpful, and increases the accuracy of the study.
So the mammogram is the diagnostic tool as well as a screening tool. So what do you think about the radiation risk? Is it?
So it uses X-ray, the same X-rays that we use when you do a chest X-ray. And it is the exact dose varies depending on the machine, the patient factors and all that, and the breast density. But generally, it's about, if you want figures, it's about 0.4 millisieverts as compared to 0.1 millisieverts of a chest X-ray, which means it's 4 times the dose of a chest X-ray. Having said that, it's a very, very low dose, and it's called negligible, thought negligible, and mammography, radiation-wise, mammography is considered quite safe.
More questions for you. How do you classify breast cancer lesions?
Yeah.
Image-wise.
We use BI-RADS, and the surgeons also use BI-RADS. So BI-RADS is the tool that we use for describing, reporting, and discussing, and even in data collection on mammography and basically breast imaging, mammography, ultrasound, MRI, all of that. So BI-RAD stands for Breast Imaging Reporting and Data System. So it has something to do with imaging instructions, reporting terminology, and data system, all that. Basically, BI-RADS has, as you can see, so BI-RADS, by the way, the copyrights are to the ACR, the American College of Radiologists. They're the ones who publish it, and they go on revising it. There is a latest revision which has come. Even I have not gone through that. There are some changes. The one before was 2013. So it has 6 BI-RADS categories. And the one we saw, we said BI-RADS 5, which means that it is highly suggestive of malignancy. Now, there are terminologies which we have not put here. So BI-RADS 0 is inconclusive. That needs additional evaluation. Let's say there is a dense breast where I think I'm seeing an abnormality and we don't have tomography. Or we have tomography. I looked on tomography also. Even then, I think there may be something, but I'm not quite sure. The patient has already gone. So I put a BI-RADS 0 and recall the patient for compression view. So that's a BI-RADS 0. Okay. And then BI-RADS 1 is negative for malignancy. We don't say normal,
No.
just because there are so many things,
Yeah.
right? So it's negative for malignancy, which means essentially the estimated risk of malignancy is 0. So BI-RADS 2 is benign. That's also risk of malignancy. This column is for risk of malignancy, it's 0. Then BI-RADS 3 we call probably benign lesions. So there is less than 2% chance. 98% we are sure that it's benign. So BI-RADS 4 has 3 categories depending on the risk level. Actually, this is mild, moderate, and highly suspicious. So 4C is highly suspicious of malignancy. So that goes up to 95%. 4A is 2 to 10%. So like it's sometimes very difficult to call whether if something is 3 or 4A. The difference between 3 and 4A in management, outcome is that 3 lesions you can follow up, which is a short interval follow-up in 6 months. But if we say something is 4, then the recommendation is biopsy even for 4A. Then BI-RADS 5, it means highly suggestive of malignancy, which is more than 95% risk of malignancy. So the lesion that we saw, I would say, is a BI-RADS 5. So there can be a little subjective element into observe, but when you use BI-RADS, everybody kind of fall into line. And BIRAT 6 is when in peripheries, sometimes we get, it's already diagnosed because due to various, issues. Then we do the mammogram, we know it's biopsy proven malignancy. Then we put BIRAT 6. That's how it goes.
So what are the challenges you face when you're reporting mammograms?
Yeah, there's so many challenges. Yeah, I've seen that we have put breast density as
Yeah.
one of the challenges. There are so many challenges. There are challenges related to the machine, which we have in our country a lot because some of the machines are old, you can't see. So reporting it's sometimes a nightmare. Then challenges related to the radiologists, because mammography is a subspecialty and I would say it's most difficult X-ray for a radiologist to report. There's a very steep learning curve. So mammography is very challenging that way. Patient factors wise, breast density is the most important thing. Because I think we just mentioned it. So the breast composition is one of the breast density or breast composition is one of the things that we comment on our reports when we report mammography, first of all. And there are 4 categories, A, B, C, D. So this is A, which means that the breasts are almost entirely fatty, which means even a tiny lesion you will see. You can, when your patient's breast composite, even before you look at the mammogram, if you see the report and it says category A or breast are almost entirely fatty, you know that the sensitivity of this study is very high. The chances of missing something is very low on the mammogram, right? And this is scattered fibroglandular density. That's also quite good. We like breast with scattered fibroglandular densities. But this breast we call heterogeneously dense. And in BIRATS, it comes with a dash byline saying heterogeneously dense that may mask small masses, obscure small masses. So that is exactly what can happen. And if there was a tiny mass, this lesion is there on always. This may be obscured, especially if this mass was little less dense. Isodense masses can be missed, small masses can be missed. This is an extremely dense breast, extremely dense that the BIRATS has put the clause saying extremely dense that it lowers the sensitivity of the mammogram. So if your patient's mammogram density is BIRATS category D, then you know that there may be a lesion which the radiologist has not detected. So all in all, before 2013, the initial BIRATS classification, I think even when we were trainees, we were looking at the amount of fibroglandular tissue. The density was decided on the amount of fibroglandular tissue. Now that is not the approach. The current BIRAT, according to current BIRATS, we look at the outcome more. Like what are the chances of a radiologist or a clinician looking at the mammogram not detecting a lesion that is there? The chances of a lesion being obscured. That is the basis for breast density. So there are 4 grades. Yeah, it is a challenge, especially these 2 categories can be challenging.
Yeah, okay, thank you very much. Yeah, so after the mammogram, we went away to the ultrasound scan, and there were no enlarged nodes in the axilla. And from the surgeons, what is the next step in the management?
Yeah, so this is a 45 lady. Looks like early breast cancer with no lymph nodes. So what we practice is the evidence is for sentinel lymph node biopsy. Depending on the availability, you have either the dual tracer technique or the single tracer technique. But I think commonly we have what is the blue dye, the methylene blue. I think Maharagama has can do dual tracer technique. Yeah, it's not readily available. So the evidence, if you look for the either the dual tracer technique or the single tracer technique, the preference is if you have both, please use both, right? But if you don't have the radioactive tracer, don't have to split your hair. I mean, you can do the methylene blue. It's very sensitive and effective, and you can do a good harvest. And the most important thing in sentinel lymph node biopsy is how much nodes you need to harvest. Now, it's true. Now, this idea in concept-wise, principally, first node that drains. But if you look at the evidence, if you harvest only the first node, the false negative rate is more than 20%, which is not acceptable. So then the study said if you harvest two nodes, that rate drops to around 15 to 16%. 3 nodes around 11%, and 4 or more nodes it drops to less than 9%, which is accepted. So number of lymph nodes matters. So it may be all the blue dye that you see, you harvest them, or if you have 1 or 2 blue dyes, but if you can see or palpate nodes, please harvest them as non-sentinel lymph nodes. So that improves your the sensitivity and reduces the false negative rate. So that's the most important thing that you need to know. Although it's sentinel node, is not only the first node.
Right. So we have a breast lesion, which is BI-RADS 5. And we went ahead with ultrasound guided core biopsy as well. And do you recommend FNACs for breast lumps?
It was started at FNAC long time ago. Still, for some other reason, it happens. Probably the resources are not available when you walk out away from Colombo, right? So core biopsy for any solid lesion of the breast, core biopsy is the gold standard now, right? If you have facilities, please do a core biopsy. If your hospital doesn't have, please refer to a hospital close by who has the facility, because it provides a lot of details. First thing, it is the confirmatory test. If you don't have, if you can't diagnose with the FNA, if it says C4, what is the next step? You again have to go for a core biopsy, right? When the triple assessment, when you say you need to have histological diagnosis, that is core biopsy. There's no place for incision biopsy or excisional biopsy. Those are out. Those are out, right? So you will violate the basic principles of cancer if you do incisional biopsy or excisional biopsy. This is core biopsy. So the other advantage is the information that you can take. You can grade the cancer. You can say whether there are DCIs. You can say what the type of histology. And immunos, that is the most important thing. So now the prognosis largely depends on the immunohistochemistry pattern. Not only the grade, not only the NPI, but the immunos matter. So if you know if the triple negative or a HER2 or just a hormone positive HER2 negative, that plays a key role. So core biopsy is the main thing. Now FNA, now you might argue, yeah, you can do immunos from the cytology as well, immunocytochemistry, but that is not available in Sri Lanka as far as I know. So, and the sensitivity is much better in core biopsies.
Thank you. So my next question goes to Dr. Priyanka. What are the different histological types of breast cancer?
Thank you. I think the surgeon answered my question. But yes, the FNAC, you think the FNAC has been used previously. When we were registrars, I think it was the fine needle aspiration cytology which was used. And at that time, even FNAC was new at that time. The people have gone for excision biopsy previously. There was no FNAC when our teachers started pathology, actually. So the problems with FNAC, what I would feel is if it's, obvious malignancy, FNAC is okay. But the core biopsy is the preferred method because it has so many other advantages, right? The advantages are basically on the FNAC, you're seeing individual cells and you're looking at the nuclei of individual cells and giving a diagnosis, but you're not seeing an architecture. But in the core biopsy, you're seeing an architecture. So the sensitivity and specificity with the core biopsy is much more than the FNAC. Breast FNAC still has a good sensitivity and specificity rate, but it is much more than, so we are very confident on the core biopsy to call something cancer. and the other things that can be used is, as he mentioned, the grading of cancer. If there's adequate tissue on the core biopsy, that depends on the quality of the biopsy as well. The grading can be done on the core biopsy. So if the patient wants to go for neoadjuvant chemotherapy, that may be the only specimen that you're getting. So it is very important that you get a core biopsy. So I think I'll be talking a bit more about grading. So the grading can be done easily with the core biopsy. And if there's in situ carcinoma, like DCIS or LCIS or versus invasive carcinoma, you can't differentiate that on a FNA. So if I say malignant cells are present from a carcinoma, it can be DCIS or invasive cancer. But on the core biopsy, I can differentiate that and say, like, this is a definite in situ carcinoma or invasive carcinoma. So, and the other advantage is doing ERPR, HER2 and Ki67 on breast cancer can be done, especially in the setting of neoadjuvant chemotherapy. That may be the only sample that's available. So it's very important you have a core biopsy because after neoadjuvant chemotherapy, the tumor may fully disappear and you won't have a specimen. So I think those are the main advantages, I would say, FNAC versus core biopsy.
And what are the different types of breast cancers?
Yeah, different types of breast carcinoma. There are basically in situ carcinoma and invasive carcinoma. So in situ is a DCIS or LCIS. So there are different types of DCIS, different types of LCIS, which I won't be talking here. Then invasive, I think what he's referring is mainly to with invasive carcinoma. So the commonest is previously we used to call it invasive duct carcinoma. Now we call it invasive breast carcinoma, no special type. So there's no special type. Others are meaning that the others have a special type, right? So what are the other special types? So commonly invasive lobular carcinomas, mucinous carcinomas, tubular carcinomas. Mucinous tubular generally have a better prognosis, and invasive cribriform carcinoma, which is also having a better prognosis. Medullary carcinoma now had been taken off from the classification. Now it goes as under the category of invasive breast carcinoma, medullary pattern. So they have taken it off from the system, I think. So it goes as invasive breast carcinoma grade 3, basically. NST with medullary pattern. Others like metaplastic carcinoma, when there are squamous areas, so glandular and stromal biphasic patterns. So and the others, there are other uncommon tumors, that's mucinous cystadenocarcinomas and salivary type carcinomas can all occur in the breast, because breast is a bit like the salivary gland. So many salivary tumors can also occur in the breast. So I think that would.
So what are the specific things you would like to mention? You would be reporting in the pathology report.
Okay. So in a pathology report, I think you're referring to a main mastectomy or wide local or something. So what are the things there? There are very important things a pathologist should mention. So the type of specimen that you get has to be mentioned. So that's why I sometimes ask, is this a wide local excision or is it a mastectomy? Sometimes it's difficult to, but just by looking at it becomes smaller breasts and so on. So what is the specimen we get? And then type of breast cancer, as I mentioned, what are the types? Is it an invasive, in situ, and the grading of the tumor? So we usually use Nottingham grading, which I'll be talking a bit later on, I think. And the site of the tumor, the size of the tumor, the margins have to be commented on, like depending on the type of specimen, margins vary. So if it's just a mastectomy, you might have a deep margin, but if it's a wide local excision, oriented wide local excision, because the specimens have to be oriented when you send to the pathologist. So you have to mention all 6 sites and how far the tumor is from the margins. and whether there's associated DCIS. And if it's there, what is the grade of DCIS, the size of the DCIS, and the percentage, whether it's extensive DCIS, when it's more than 25%, or whether it's away from the tumor, that has to be commented. Whether there's lymphovascular and perineural invasion is important. If the nipple is there in the specimen, in a mastectomy specimen, you have to comment about the presence of Paget's disease, whether it's there. If the skin is there, if there's ulceration, and how far it is from the skin. Non-neoplastic breast tissue, whether whether there are any changes, or is it normal, or fibrocystic disease, or any other benign pathology is there in the non-neoplastic. And sentinel nodes or axillary clearance or whatever the lymph nodes you are getting. And the nodes, whether how many are positive. I mean, if it's a single node positive, we have to give the tumor size because that stage in the node. So that changes the staging if it's a micromet or macromet. And if there's perinodal extension in the nodes, that has to be mentioned. Staging, pathological staging has to be mentioned. And receptors, if it's not done straight away, if a co-biopsy report basically has receptors now, because most of the time it's a co-biopsy, we do the receptors. So whether it'll, I mean, usually you won't report it then and there. What we do is co-biopsy, ERPR HER2 to follow. And actually, if it's not there done straight away, you have to mention the block. This block can be utilized for your hormone receptors. So I think I covered most of, yeah. Yeah. So in the request form, if neoadjuvant has been given, you have to mention that. You have to mention that because we get so many specimens. Sometimes people forget to write because when I cut the breast only, I realized no tumor in this thing. And then I looked for the biopsy and biopsy had been done weeks, months before. And then only I realized, oh my God, chemotherapy had been given. Otherwise we get puzzled. How come there's no tumor in the breast? So that has to be mentioned. And if there's neoadjuvant chemotherapy, we would like you to comment about the, in the request form, the co-biopsy, what was the grading, what was the size of the tumor and the site of the tumor, because that only helps us to find the tumor bed in the specimen. So, we have a separate request form at Maharagama. So we want all of you to fill that properly when you come there. Otherwise, we keep calling registrars to come to the lab to find the tumor site. But yes, so so based on the neoadjuvant chemotherapy, like, you know, we have to comment about, like, you know, what is the tumor bed size and about what is the percentage of positive tumor if it's there, or if it's not there, if there's complete pathological response. So for all that, we have to know the previous history. Ink on tumor. You mean when I report? Yeah. So if the margins are positive, like, you know, so when we give margin, you have to give the distance. So how we measure margins is by inking the specimen. So basically, if it's a mastectomy, I would just put 1 ink for the deep aspect because that's the only male margin that I'm worried about. But in a wide local excision, I would be marking with different colors, like, you know, superior different color, inferior, because usually there's a skin on the superficial aspect and you send that with the skin ellipse. If not, you have to mention, you usually put 2 sutures, no? Short superior and long lateral. And skin ellipse is there on the superficial aspect. If it's not there, then you mark that aspect as well, so that it's easy for us to orient. Then after that, I apply ink to different aspects, like different sides. Usually I use about 6 inks for all 6 sides. So each and every one, like, you get a section from each side to measure the distance to the inked area. So what he mentioned was if the tumor extends to ink, like, you know, if the ink touches the tumor, that is a positive margin for us. So even if it's not positive, we are supposed to give the closest distance from the invasive tumor. And if the DCIS extends above the invasive focus, then that has to be mentioned how far it is away from the DCIS as well. So orientation is also very important. So if you put sutures, please write.
We'll be coming a little bit more on margins the next, right? Okay. So how would you grade the breast cancer?
Okay. So invasive carcinomas, in situ carcinomas, you know that low grade, intermediate grade, and high grade types of DCIS is there. So that type of grading now the grading of DCIS occurs from the nuclear grade. So just looking at the nuclei and how bad the nuclei look like. So if it's very pleomorphic and high grade looking, we would call it high grade. So the nuclear look low grade, there are certain features to call nuclear changes. So that would we call it low grade. Something in between is intermediate. And there are other factors, necrosis, calcification, all that matters. But basically the grading is done from the nuclear currently. Invasive cancer is graded from the Nottingham grading system, which is, it has been modified quite a few times. But grading correlates quite well with survival and aggressiveness of the tumor. So grading is grading of breast carcinoma is a must. So I think even as surgical registrars, you are supposed to know how breast grading is done. So what are the components? There are 3 components of grading of breast cancer. Number 1 is tubule formation. So how many tubules, how much tubules are there? Now tubules are a good factor in breast, right? So having tubules stimulates more, looks very similar to normal breast tissue. So more tubules, lower the grade, right? So if it's more than 75%, I would give a score of 1. Okay, if it's less than 10%, I would give a score of 3. So if somewhere in between, I would give a score of 2. So like that, 3 grades. So tubule formation, nuclear grade. So how pleomorphic the nuclei look like. So that has 1, 2, and 3. So nuclei has 3 grades. And mitotic count. Mitotic count. Counting mitosis varies depending on their field diameter. So previously we used to use 10 high power fields and count. So high power is 40 in the microscope, 10 above. So it's about 400 magnification. So we used to use 10 high power fields and give the number. So if it's then 7, it would be graded as 1. If it's more than 15, it would be called 3. Now, this is from a normal microscope. Normal microscope meaning most of the trainees use the normal microscope, but different, like my microscope is a bit more advanced one at Maharagama. So the field diameter is a bit more. So because of that, they have changed and it into a field, not 10 high power fields. Now they say 2 millimeter square. So for 2 millimeter square is equivalent to 10 high power field in normal CX33 microscope. So, so that varies. What I want to tell you is that the mitotic count varies depending on the type of microscope you're using. So the pathologists know which, how many fields they have to count to get the mitotic count. So all that has to be added, right? So altogether you have 9. So if the count is between 6 and 7, that's how I remember, 6 and 7 is grade 2. So grade 1 is lower than that. 8 and 9, it's grade 3. So that's how grading is done. I think it's easy to remember. So it's better because sometimes if there are mistakes in the path reports, even the surgeons can identify that if you know it. Okay.
Dr. Mahila, what is the importance of grading and how does it affect your treatment or management?
Yeah, so grading is very important actually. So after nodal status, I would say grading is the most important thing that we look at in the pathology report, because for high grade tumors, grade 3 tumors, even if the tumor is very small, node negative and cleared completely, still there will be a risk of microscopic spread and patient will require adjuvant treatment after complete surgery. And for low-grade tumors, so low-grade tumors, if the tumor is grade 1 and if other parameters, example, receptors are favorable, then that sort of a patient could be followed up. So in deciding adjuvant treatments and on a core biopsy in deciding even neoadjuvant treatment, grading is one definitive indication to offer chemotherapy, either neoadjuvant or adjuvant. So grading is very important.
So higher the grade, the chemo response is better or not? What do you think?
Higher the grade chemo response is better is, I think, indirectly related because chemo response levels are proven in relation to receptor status. For example, if a patient is having ERPR positive, HER2 negative tumor, then complete response or response rate with chemotherapy is fairly low. But for patients with HER2 positive tumors, response rates are very high. And triple negative will lie in between. So grading also corresponds with the receptor status most of the time because most of the ERPR positive tumors are low grade, but there are exceptions and most of the HER2 positive or triple negative tumors are high grade. So grading is indirectly related to the response rates.
So more aggressive tumors have better response to chemo.
More aggressive
Even though
tumors
they-
are having better chemotherapy response and complete response
Response
rate.
is
But
better. Even
that
though
is
their
not-
prognosis is not good.
No. HER2 positive, I think may be the one with best prognosis nowadays.
Yeah, because of the treatment.
Yes. So grading, even though those tumors are high grade, they are doing even better than ERPR positive tumors
Yeah.
with modern treatment.
Right. Thank you. So this is our histology report. So it came as invasive carcinoma, ERPR positive, HER2 negative, and T2 N0 MX. And Dr. Mahilal, what is the place of neoadjuvant in this case? Will you offer neoadjuvant for this patient or not?
For this patient, its clear answer is no, because it's a 2.5 centimeter tumors without nodes. So in giving neoadjuvant treatment, my practice is actually I look at the nodal status first. So in basic thing is if you have any indication for chemotherapy on the clinical assessment, it could be the tumor size, it could be the pathology core biopsy report. So if you get any definitive indication for chemo, then you can give that chemo either neoadjuvant or adjuvant. Because giving chemo neoadjuvantly or adjuvantly will not change the outcome. It will have the same benefit. So as soon as you find the indication to give chemotherapy, you can give it neoadjuvantly. So here on this is grade.
Grading I have not mentioned.
So I assume this is grade 1 or 2.
Yeah.
Then there are no definitive indications for chemo. So this patient and one other important thing is sometimes there can be a patient with fairly big tumor for breast conservation. But on histology, there may be no definitive indication for chemo. So just for downstaging, we don't offer chemo. That means just to facilitate the breast conservation, we never offer chemo. Chemo indication we looked at separately. And downstaging is not a chemo indication. So that you have to remember. I don't know whether you are clear about what I am saying. Because for example, if a patient is having 3.54 centimeter tumor in a patient with small breast, but grading is low, ERPR positive and no nodes, that means that patient is not having definitive indication to chemo, to give chemo. So for that patient, purely for the purpose of downstaging to facilitate breast conservation, we can't offer chemo. That is not an indication to give chemo. And this patient, anyway, it's surgically operable, no indications for chemo. I will not consider chemo at all.
Right. So now we have a patient who is 42 years, T2 N0 MX tumor, which is ERPR positive, HER2 negative, and axilla is negative. So what would be the surgical management of this patient?
even though it says early, I mean, it falls into early breast cancer. So surgery, I think, is the first choice rather than going for neoadjuvant, as Mahila correctly said. So I think we have to do few basic investigations just to check the early breast cancer workup. So at least ultrasound scan, abdomen, alkaline phosphatase levels, and chest X-ray. Then, as you have seen, the mammogram is she's having a sizable breast and so lump is small. So the preferred choice is the breast conservation if the patient is happy. And since the axilla is clinically and radiologically negative, and so I do sentinel lymph node biopsy, preferably dual tracer if available, or methylene blue, which we are commonly use.
Right. So,
And one more thing, there are some patients, I mean, it's always the patient's choice. So if the patient prefers mastectomy, we offer mastectomy. And if the patient is happy or going for reconstruction, that of course we can offer reconstruction, either autologous or implant-based reconstruction.
Shall I add a thing there? Because now patient preference, that is a relative thing, I would say, because now patients at the time of surgery, they want to get rid of it completely. So they say that I need mastectomy. And those patients then come to us and they stay with us for many years. Then their survival is good. So with time, they face a lot of social issues after mastectomy. So I think it's our responsibility to tell them about the equivalence of mastectomy versus breast conservation. And recent data suggests that wide local excision patients are having even better survival compared to mastectomy. And after mastectomy, their upper limb movements are restricted with time. So that is a common problem we see in these patients undergoing mastectomy. So I tend to little bit disagree on patient choice on decision making between mastectomy and wide local excision, because patient is not in a position to decide the best treatment. When we give options, if the options are equal, they can decide. But if we say that mastectomy is having these problems and wide local excision will also have the same or even better outcome, I'm sure they will agree with wide local excision. And one other thing that we observe is, I mean, now in our country with the limitation of radiation facilities, actually there are delays in giving radiotherapy. So because of that delay, some surgeons are offering mastectomy. But I think that practice also should stop, because delays in radiotherapy will not affect that much when it comes to breast cancer outcome. That matters for cervical cancer, head and neck cancers, like cancers we manage with radiotherapy.
what is the ideal time? Yeah.
Ideal time? Because if you are giving chemotherapy, then even delay of a few months even after completing chemotherapy will not matter.
If the patient is getting some kind of treatment, you
Some
can delay.
kind of other treatment.
If
And
not-
if hormone positive patients, again, delay will not matter that much. But it may be having more impact with relatively higher grade tumors. And if you are not giving any adjuvant treatment apart from hormones, then we keep about 4-week gap from surgery to radiotherapy. And that is the ideal time to give radiotherapy. But because these are relatively slower growing tumors, I don't think delay will matter that much compared to some other tumors. We categorize them as category 1, where delays will matter more. When it comes to squamous cell carcinomas, delay will be detrimental to the patient. But when it comes to breast cancer, delays will not matter that much at least. And delay should not be an indication to offer mastectomy. That's what I think.
What is the radiation delay in your center usually? Yeah.
Radiation delays are, it's variable. So for patients who are getting adjuvant treatment, there is not that much of a delay. But if the patient is just requiring hormones, then there will be a delay of about 3 months, I would say. So ideal time is 8 weeks. So 3 to 4 months time we are starting. And nowadays we give 5-day courses.
Yeah.
So 5-day radiation. So with that, we manage delays in much better way compared to few years back. Because now recently with COVID, that is one good thing because during the time of COVID, people investigated various schedules, short schedules to give radiotherapy, and 5-day schedule seems to be proven to be equivalent. So now we offer 5-day schedule for patients who does not require axillary radiotherapy. So almost 80-90% of patients can get a 5-day schedule. So with that, we minimize the delays. And so mastectomy versus wide local excision, I think you all will be the ones who will be taking over in 5-10 years time, surgical management of breast cancer. So I think it has to be wide local excision now.
So what you mean is you have to give adequate information before taking the decision.
Yes, yes, because
About the survival and the social issues and
if we
everything.
give those information, I don't see any patient requesting for mastectomy because they have a belief that if you can get rid of everything, they will be cured. But I don't see any patients dying of local recurrence. So what they get is distant metastasis, and distant metastasis rate is not at all related to mastectomy or wide local excision. So that information we have to convey correctly.
Yeah, there are certain social issues that I have seen. I work in Ratnapur, so we don't have radiotherapy there. We get a lot of these state sector patients with breast cancers. And when we offer wide local excision, they can't come to Colombo to get radiotherapy. So those type of things, and they have a lot of family issues if they leave the house and everything. So we face those type of problems as well.
Ratnapura will get a linear accelerator very quickly.
Yeah.
Yeah, usually we, what I do is I offer all three treatments: mastectomy, wide local plus reconstruction. And I tell them specifically all three modalities has equal outcome, and there's no any disadvantage of each technique. So the patient decides what to do after telling everything. And the other option is even after mastectomy, if the patient is going for mastectomy, there's always there's a place once the treatment completed, they can undergo delayed breast reconstruction, which has good results because most of the Sri Lankan women have big bellies. So they have two advantages, abdominoplasty plus breast reconstruction. So that's the thing we can offer, delayed breast reconstruction if the patient is going for mastectomy in initial phase.
So I agree with Dr. Mahila also. You need to give the adequate information to the patient. From your point of view, as you are trainees, one trial, if you want to quote, is the Milan trial, which came in 1980s. So it had 3 arms comparing mastectomy, quadrantectomy, then the quadrantectomy plus radiotherapy. And they had more or less equal results with the quadrantectomy plus radiotherapy equivalent to mastectomy, somewhat better results in the radiotherapy group, but not the quadrantectomy only group. So, and the other thing is the patients fear it will come back, so it will recur. But even if breast cancer is going to recur, it's not in the breast or the chest wall, it's elsewhere. And as Dr. Mahila said, no one will die of skin recurrence, but they will recur, right? So you have to give enough evidence. And other thing is, some patients, you will think of doing mastectomy, even if it can be done with a wide local because of other reasons, if there are contraindications for radiotherapy. So just think if they have undergone previous radiotherapy where you can't give radiotherapy again. Some patients have very arthritis or other changes in the arm. They cannot position the patient for radiotherapy. Then the soft tissue conditions, you cannot give radiotherapy. Just look into these details as well, minor points.
Dr. Nalin, what are the contraindications, absolute contraindications for wide local excision or breast conservation?
For breast conservation?
Yeah.
Absolute.
Yeah.
So absolute contraindications are becoming, they are becoming less and less. So when I was a trainee a couple of years ago, multifocal, multicentral, everything was contraindicated, right? Now it is not so. Even I have done 3 lesions in the same breast, wide locals, wide localizations. If you look into the literature of Mike Dixon from Edinburgh, he has produced a lot of papers on multifocal and multicentral lesions with breast conservative surgery followed with radiotherapy. So the contraindications are becoming less. So other thing is if you cannot give radiotherapy after breast conservative, that's absolute contraindication. And recurrence of breast cancer in the previous irradiated breast, then you can't do again a wide local, but you can think of doing a conservative mastectomy apart from simple mastectomy.
What about your skin involvement?
Skin involvement now, if it is now, don't get this wrong. Skin involvement in oncological point of view, it's the to say T4B only qualifies 3 factors: body orange, direct ulceration, and metastatic skin nodules. Tethering is wrongly interpreted as skin invasion. It is not so. If you can take the skin over the tethered area safely, and if you think it's not going to necrose, that's fine. Otherwise, you can incorporate, but routinely in wide local excisions or granthectomies, you don't have to include a skin island. It's not so. Now, the problem comes when the pathologist report the superficial margin. Now, the margin, we are talking about the radial margin, 1 millimeter or more. If it is deep margin, we are going to go in again and dig into the pec major. Superficial margin, it is now taken out. It's not considered as invaded. If it is less than 1 millimeter, that is okay. You radiate the breast. You are not going to go and again and take the skin island. It's not necessary.
If a local island of ulceration, would you do a wide excision?
If it is ulcerated.
Yeah, only a local area.
So if it is ulcerated, it's a T4B. So then anyway, it has to be undergo imaging chemotherapy. And depending on the response, you can decide on doing a wide local or a mastectomy in terms of, you can even do skin reducing mastectomies apart from nipple sparing and skin sparing. So you can do that. So, but it's not contraindicated to go for a wide local.
Okay, thank you. So, yeah, what are the advantages of doing sentinel node biopsy or axillary clearance from the surgeons? So, yeah.
So actually, earlier, long time before, the trend was to do axillary lymph node clearance level 1 and 2. Now it has shifted to sentinel lymph node biopsy for negative radiological and clinical negative axilla. In fact, recently there were some recommendations from NCCN guidelines. If you tumors harvested at least 3-4 lymph nodes, where 2 lymph nodes positive and favorable histochemistry like ER negative positive, HER2 negative, of course you can omit axillary clearance, provided that the patient have wide local excision sentinel lymph node biopsy followed by radiotherapy, including the axilla. So in that situation, of course, you can avoid axillary clearance. Those are only tumors with favorable the factors. So sentinel lymph node biopsy is the standard treatment for clinically and radiologically negative axilla. But of course, if the axilla is positive on the diagnosis, the axillary clearance will be an option.
So, in this case, what are the options for the tissue loss? If you're taking a large area of tissue with wide local excision, what are the options you have?
So nowadays, the breast surgeons are provided a lot of options, right? So few things matter: size of the breast, the quality of the skin, and the size of the tumor, right? And the location of the tumor, right? So depending on these factors, you can decide what whether you can go for a level 1 or 2 oncoplastic technique, or just put a chest or perforator flap. So you have LICAPs, MICAPs, ICAPs, TDAPs, or all the possibilities are there. Even the mini LD flaps after wide local is not a bad thing. So all these flaps are there. So those are the factors to consider: size of the breast, skin quality, and the amount of the size of the tumor, and the site of the breast, the tumor location. So these are the things. So this patient per se, I don't know where the location was.
That was out.
Yeah, 9 o'clock. So the size of the breast, I don't know if it is amenable. You can put a transverse incision, which heals beautifully, and you too can do just a simple wide local excision with direct closure with mobilization of the glandular flaps. But if it is a smaller breast, like now this also needs to, in other countries, people are aware it's about the breast size, how to communicate the breast size. In our country, it is not so. So if you have, even if you meet medical students, what I do, I teach the medical students. I can't teach the patient. So I teach the medical students, hoping they will take this knowledge. So about how to communicate breast size in terms of cup size. So if the think that the excision is going to leave a wider cavity, a large cavity, you can put a LICAP or a Tdap flap for a 9 o'clock position tumor. Or in between what lies is a where you can do a wide local mobilized tissue the recent tracks lateral complex that will also give beautiful results.
Thank you. So what are the techniques for sentinel node biopsy?
I think I told before that you have different tracer techniques, the radioisotope scan and the blue dye. What we use is the 2% methylene blue. The percentage is important. If your hospital doesn't have the sterile vials, which are with 2% methylene blue, if you have to make with the powder, make sure you go to the lab and measure it and get it to the correct strength. Otherwise, very diluted methylene blue will not give you, take you anywhere with the sentinel node biopsy. And the technique is we all inject it to the subareolar sapphire of lymphatic plexus. If you go deep down, then it's also not good. If you be very superficial, you also nipple area complex will necrose. So be aware. My experience, if you give it about 2 millimeters, 3 millimeters below the nipple area of the skin, it will work beautifully because it hits the target of the lymphatic plexus of sapphire. Tumor, the other location. Even with upper quadrant tumors, subperitoneal injection has worked beautifully. But if you think it is going to obstruct, if it is a large tumor sitting upper quadrant, blocking the lymphatic pathway, you can inject the tumor as well. But my experience is subperitoneal works beautifully in that case as well. So yeah, we talked about both techniques. So if you are doing a isotopes study, inject it half an hour later, you can go into the axilla and you can with the handheld gamma probe. First you measure the background radiation, and then if it would be at least 10 times more than the background radiation, to call it a hot node. So you can harvest that node from the nodes that are blue. Sometimes the blue node, they will do the gamma probe as well, right?
You do that in Hargan, so we all can see that the gamma. Do you have a gamma?
No,
probe in your-
I'm at Raga. We don't have isotope or gamma probe. I'm just telling the experience I had. So if you have it at Maharagam, if you can see, so these are things to look into. So you have to measure the background as well as it should be 10 times more than the background radiation. And other thing is the targeted techniques, I think we'll be discussing them later, right?
So you prefer this thing, you don't have the facility, but the ideal would be the dual tracer technique, isn't it?
Yes, yes. So, but if you don't have the dual tracer, there is good sensitivity and specificity with methylene blue as well. And sometimes, what in practical point of view, very rarely you will find that you open up the axilla, no, nothing, no palpable node, and no sentinel node also. What can you do then, right? So, if you have nodes that are palpable but not blue, there's you can do axillary sampling, right? Please don't carry out with unnecessary axillary clearance, right? For you, it's just 20 minutes, but for the patients, it's the entire lifetime, right? So you don't want to have a history report says, okay, you have 20 minutes, none of them are node, right? So don't do that.
So what are the newer techniques for sentinel? Do you have any?
Yeah, if it is the target technique, they are the endosigning beam techniques are there, but they are not used in other countries also. They are not in routine use. So you can, now when you get sentinel node biopsy, if the radiologist say that you have a suspicious node, if it is only suspicious, if the radiologist is not confident to say it is involved, you can always ask them to do a FMO for you. And if it is positive, you can target the lesion with a clip or a coil. Coils, is it available? Coils? Right, you put clips, yeah, because clips can be seen in the ultrasound scan. Or when you open up the axilla, when you get the node with the methylene blue as well, when you get the node, you don't know whether the clip is inside, so you get a specimen mammogram of the node, so you can see the clip. So these are available,
Yeah.
and the other countries, they have these other neuromagnetic seeds and
Yeah,
things.
they have these metallic traces now. They are replacing
Yes,
the oil.
yeah.
I mean, still they're using the methylene blue and with the metallic traces rather than these radiational ones,
Yes.
mag traces and.
Yeah, so magnetically, it does good, but the thing is, it's very expensive. Even in UK, it's very expensive. So the patients who NHS, well, it was a trial going on when I was there. So with that trial, they did it.
Now
but,
they are increasingly using it.
Yes, yes, because the isotope near the
Yes.
you don't need isotope. That's the thing.
Because there are a lot of
Target.
regulations with isotope, you can't use it in all the hospitals.
Yes, that's true. And this is what we are going into this targeted X-ray dissection. It's a new concept. It's not X-ray, it's not sentinel node, it's targeted X-ray dissection.
So we went ahead with wide local excision and sentinel node biopsy. So histology, invasive ductal carcinoma 2.5 into 2.5 centimeter, margins 0.5 centimeters. But there was DCIS reaching the superior margin, ERPR positive, HER2 negative, 4 sentinel nodes, 2 positive. So yeah, from oncologists and the surgeons, what would you suggest in this situation? And what are the expected margins for breast cancers? What would you expect now?
Yeah, the expected margin for invasive cancer is 1 millimeter. DCIS is 2 millimeters. So here DCIS part is reaching the margin. So it can be considered as margin positive resection. And also 2 out of 4 nodes are positive. So those are the 2 problems in this report in this patient now. So for the margin, she's 45 and initial assessment was done with mammogram. So these patients actually, when they come with the positive margin, especially positive margin with DCIS, I prefer to do a MRI before attempting the next surgery. Because otherwise, sometimes we see some patients go for the second surgery and come
Again,
with
margin
the
positive.
positive margin
Yeah.
again.
Mm.
So I think surgeon can plan the next resection appropriately if the MRI information is provided, because MRI is more sensitive than mammogram in detecting breast lesions, especially DCIS. And the management of 2 positive nodes. So sentinel nodes, if 2, 3, 4 nodes are removed and if only 1 node is positive, then there is enough evidence to avoid axillary clearance. So we don't send the patient for formal axillary clearance if only 1 node is positive. Is a difficult situation because some studies show that even with 2 or 3 positive nodes, axillary clearance can be avoided, but those evidence are not very conclusive. So my personal practice is to send the patient for axillary clearance in this situation. So this patient, I will arrange a MRI, and with the MRI, will recommend or will arrange cavity shave plus axillary clearance.
Dr. Nalinder, what is your margin state? You take 1 millimeter, no ink on margin. What is your, what do you?
So if you see in Sri Lanka, it's 1 millimeter. We all agree upon that. The British guidelines says 1 millimeter, no question about that. But if you see the American guidelines, they say no ink on margin. So we stick to whatever the guidelines, please stick to the protocols in your country or the center that you are working, right? So yeah, margin safety, if it is DCIs. Now, if I know the grading of the DCIs, if it is high grade, surely I will agree with Dr. Mahal. I go for another shaving after MRI, of course. But if it is low grade, because this patient is going for radiotherapy, if it is just, if it is inward margin, yeah, I will take. Otherwise, it is less than 2 millimeter, I will just give radiotherapy alone. I won't subject to another shaving.
You would go for MDT and discuss.
Sorry?
You would go for the MDT and decide on it.
Of course, all patients go through the MDT. None of them escape the MDT. And about the center nodes, I agree with Dr. Mahila. Yeah, we do. we don't do unnecessary axillary clearance. And what we do is, even if there are two nodes positive, we don't do axillary clearance, we give radiotherapy. And my series, they haven't had axillary recurrence, but I have a very short database. It has about 5 years. So for this short period, I haven't had any adverse events, but yet to publish the results. So, I think we can safely avoid the axillary clearance, because if you see the studies, if you subject these patients for completion axillary clearance, the report says no positive nodes after that. So these are unnecessary clearances. So yeah, node positivity, my stance is, I think we can safely avoid unnecessary clearance if we can irradiate the axilla.
Dr. Udari.
Actually,
Sorry.
We do not irradiate the axilla routinely after breast conservation, but level 1 nodes will be included. When we are irradiating the breast, actually level 1 group will be irradiated. We don't really want to irradiate them, but the technique is such that level 1 will get adequate dose, but level 2 and 3 will not get radiation unless we formally include the axilla. So what he is saying is, now if 1 or 2, 1 node, actually there are enough evidence. It's proven that axillary clearance is not required. And problem is with 2 to 3 nodes, because different people have different opinions. So some will not go for axillary clearance because there are some evidence to avoid that. Some go for axillary clearance because, I mean, what really happens is, for example, this patient, if this patient goes for radiation without going for axillary clearance, still level 1 axillary group will get the adequate radiation dose to sterilize any microscopic disease. So they tend to do well even without formal clearance. But we lack solid data to say that axillary clearance can be avoided. We can't solidly say that axillary clearance can be avoided. For your exam purposes as well as, I mean, your training purpose, this is a controversial group, and current standard is to do axillary clearance because more than 1 node is positive. But there are groups who avoid axillary clearance, and management also is respected.
So you suggested an
NCCN guideline, latest guideline, they say they have quoted 2 trials, and they say T1-2 tumors, breast conservation and sentinel lymph node biopsy. If there are 4 nodes harvested, if 1 or 2 nodes are positive, then if you are doing irradiation with additional dose to the axilla, then of course you can avoid the axillary clearance. Yeah.
Yeah, additional dose to axilla. If we are irradiating the axilla, you don't need. Even you can completely avoid axillary clearance. Even you can avoid sentinel node. Because if we are irradiating the axilla, then axillary surgery is not required. But problem with axillary radiation is that has a significant risk of lymphedema. And so surgery also, you tend to avoid axillary clearance because of that risk of lymphedema. So level 1 group, we irradiate without intending to irradiate it. That is the technique. Radiotherapy technique to breast will include level 1 invariably. But we don't, if we are irradiating the axilla, that means we are purposefully including level 1, 2, 3, and 3, all 3 groups. So if we give radiation like that, then the risk of lymphedema comes. So if axillary clearance can be definitely avoided, if we are including axilla, whole axilla. But with 1 node, we don't formally include axilla, still level 1 group will get radiation and lymphedema risk will be same. It will not be changed because we will not be including level 2 and 3 purposefully.
Yeah, okay. For summarizing to the trainees, the conventional thing is, if you have sentinel node biopsy, positive sentinel node biopsy, you go for axillary clearance. That is the conventionally, that is what we used to do. But current evidence is such that if there's 1 node, there with certain criteria, you can avoid sentinel node biopsy. But for 2 nodes, there are certain uncertainties at the moment. So for you all,
So, this is the exact thing. Still, all over the world, nobody knows what to do for the axilla. Right? Controversies are there. And now they are trying to avoid axilla altogether, not even center node biopsy. If you look at the 2023 sound trial from Italy, Milan, so they are producing evidence. It's not in the real practice, but they are providing evidence. Early breast cancer T2 up to T2, no ultrasonically detectable nodes, then you can avoid axillary surgery altogether, irrespective of the immunohistochemistry status.
You may be wondering why we are discussing this 2-3 node thing this much. That discussion, not only here, worldwide, that discussion goes on because of the risk of lymphedema.
Yeah.
So everybody wants their patient to not to get lymphedema. So doing second axillary surgery will increase the risk of lymphedema. And including all axillary nodal groups in radiotherapy again will increase the risk of lymphedema. So ideal scenario is to avoid the axillary surgery and avoid the inclusion of axillary nodal groups. So with conventional breast only radiotherapy, still patients with one node will do equally. That is proven. And 2 to 3 nodes also seems to be doing equally, but evidence is not yet conclusive. So that is the conclusion, I think.
For axillary clearance, you get about 16 to 20% chance of lymphedema. But it comes down to about 4% when it goes to sentinel node biopsy. So 1/5. So that is why we are trying to do more sentinel node biopsy rather than going for axillary clearance. So from Prof. Dari, so he was suggesting MRI for a close margin. So how long do you have to wait for an MRI and after an operation? Is there a time?
So yeah, we can do MRI, go ahead, because we rely on the dynamic contrast enhancement. But how long does it, what is the time gap that is crucial for you, like management wise?
So this sort of a patient, now the thing is she is not positive. So time delay is also important. But if a patient is just having positive margin on wide local excision and if all nodes are negative, then time factor is not a major concern. Here time factor is also a concern, but I think as an oncologist or as a surgeon, I think what we are looking at in the MRI is actually we want to do MRI to exclude gross involvement of breast with DCIS. If the MRI is just inconclusive around the cavity, I mean, I think Nalinda or Dileep will be in better position to answer. So I don't think you will be worried if it is not extensive, isn't it?
Yeah, if it is not extensive and if your histopathology says it's low grade, so then we will agree with that and we can go ahead with the oncological management. But if the radiologist says there's extensive involvement of DCIs, not necessarily in the tumor bed, elsewhere. So because of the mammogram, we will not identify this. So then we are worried, then we have to think of even doing any other surgical to remove that area as well, or a conservative mastectomy.
Yeah, I mean, if the positive margin for DCI is, if it is focal thing, probably we might not worried much.
And regarding DCIS, now this is our first patient who did not have any microcalcifications, right? So here we are looking at non-calcified DCIS basically. So MRI is good at very sensitive detecting DCIS, but MRI can mislocate DCIS. So there is an issue there. If time is not a factor, it's good to wait for like 4 weeks, because the position, there are logistic issues also. One thing is enhancement, other thing is logistically, because the patient has to lie down flat on a breast cup. So the patient might not like it because the breast gets a little bit uncomfortable and it's engorged. So we like to wait, but if there is, if time is pressed, we can go ahead and do it.
So yeah, after an MDT, we decided to a re-excision of the margins and axillary clearance was carried out. So it was free of tumor and all nodes were negative. As they said, most of the time that is what we get. So So what is the adjuvant treatment plan for this patient?
So this patient now is not positive. Node positivity is the single most important prognostic factor in locally advanced breast cancer. So node positivity means she is having significant risk of micrometastasis. So she will require adjuvant chemotherapy. That is a definitive indication. And chemotherapy benefit will be significant here. So she will require adjuvant chemotherapy. And when it comes to adjuvant chemotherapy, so she is ERPR positive and HER2 negative. So standard adjuvant chemotherapy is actually anthracycline based and taxane based. So usually for node positive patients, we combine both. So it will be sequential. So initially I would start with anthracycline based chemo for 3 cycles, followed by taxanes for another 3 cycles. For example, if this patient is having high grade disease without nodes, then I will be only giving anthracycline based chemo for 6 cycles. That is for ERPR positive group. And I don't know whether I should tell about HER2 thing here or are we getting another chance? Yes. Yeah.
So chemotherapy.
And radiotherapy. So she will require radiotherapy. And here the indication is actually now, if this patient had no nodes, then the radiotherapy indication is only breast conservation. But here this patient is having 2 nodes. So those 2 indications are different when it comes to radiotherapy volume and technique. Because this patient, even if she had undergone mastectomy, she would still require adjuvant radiotherapy. So that's why I said, it's a common practice to offer mastectomy to avoid radiation, but ultimately patient comes with this sort of a report. So anyway, radiation is required. Even if this patient had undergone mastectomy, she would require radiotherapy. So that's why I said that to avoid that sort of a practice. So here radiation indication is definitive, not only breast conservation. So she will require radiotherapy to breast and also nodal groups, axilla, supraclavicular fossa. And axilla we avoid because axillary clearance was done. So breast and supraclavicular fossa radiation followed by breast boost. So cavity we will be boosting and we need surgeon's help in planning cavity boost because we have to locate the tumor cavity correctly to offer cavity boost. And best method to locate the tumor cavity is the seroma. So patient will be fortunate if she had developed a small seroma because then we will exactly know the tumor bed. But some patients actually will get collapsed cavity and we can't see anything unless you put surgical clips to the tumor bed. So that is very, very important practice because we get patients with after wide local excision and cavity boost is required, but we can't identify the cavity. And preoperatively, most of the time they do only mammogram, which is 2-dimensional imaging. So locating the tumor cavity based on 2-dimensional imaging is also not accurate. If the patient has had CT scan or MRI scan before surgery, then 3-dimensionally we can still locate the probable tumor cavity, even if clips are not inserted. But based on mammogram, if we try to locate the tumor cavity, then either we will be radiating a very large portion of the breast because to cover those inaccuracies, we will be irradiating the wrong place. So please remember to insert clips when you do wide local excision. And cavity boost, evidence-wise, boosting will have a benefit only in younger patients. But since boost will be not having any other side effects, additional side effects, I offer boost even for older patients. But technically, if the patient is above 50 years, the benefit of cavity boost is not very significant. But younger patients, this patient is 45, so she will benefit from cavity boost.
With the current local mobilization techniques, more and more you can't rely on the seroma because you get lot of breast
Yeah,
tissue mobilization. So
No, as surgeons, we like to see very minimal or no seroma.
Yes.
But it's inevitable. So now the serum, yeah, yeah, it helps. It helps as us as surgeons when we have to do a cavity shave.
Yeah.
So when there's seroma cavity, it's help us to identify the cavity, no argument. But the current practice, when you have the flaps, when you put flaps, the seroma is much less, the cavity is much less, although there can be a bit of edema. And it, as you mentioned, it's vital to mark the cavity with clips. If you don't have the smaller clips, you have the Liga clips that you apply for lap chole patients. So you can use that clip as well. So make sure you have clips or plan for it when you are going to do a wide local. At the end of the day, you don't want to have a wide local excision with no clips in the patient because the adjuvant treatment will be chaotic and it will be hectic for the oncologist.
And to avoid that confusion, actually, we have the option of giving the boost part at the time of surgery. So when the surgeon is removing the tumor, we have radiation machines where we can take the machine to operating theater and treat the tumor cavity with low energy X-rays. So then accuracy will be 100%. And we have just requested the machine to Karapiti yesterday, so we'll see.
what about the hormonal treatment for this one?
Yeah, so yeah, hormonal treatment. So hormonal treatment is required. So adjuvant treatment will be chemotherapy followed by hormones. So hormonal treatment, she's 45. So I assume she's premenopausal. But nowadays, there is proven benefit with complete ovarian blockage. So this patient will require medical oophorectomy because you don't have to do surgical oophorectomy because what we need is 5 years of hormone blockade. So we use goserelin for that purpose. 5 years of goserelin, and goserelin plus aromatase inhibitor is the standard treatment. It's no longer tamoxifen. And 5-year period of goserelin plus aromatase inhibitor, and also we give zoledronic acid or bisphosphonate to cover the possible side effects of possible osteoporosis with aromatase inhibitor. And even zoledronic acid or bisphosphonates are proven to increase the survival also by very small percentage.
Would you do a DEXA scan as a baseline for all
Yes,
patients?
DEXA scan always we do when we start aromatase inhibitor. So DEXA scan, my personal practice is if the T-score is more than -2, that means if the patient is having significant osteoporosis, I give zoledronic acid 3 monthly, and otherwise as a standard, I will give 6 monthly.
How frequently do you do the DEXA scan? Yearly or 2 yearly?
No, yearly I don't do. If the initial bone density is good, I might not do any DEXA scans for next 2-3 years. But if the patient is having significant osteoporosis, maybe 1 year or at 2 years, I will repeat to see whether the osteoporosis level is at least stable and not worsening.
How long do you give aromatase inhibitors? 5 years?
Aromatase inhibitors, 5 years.
5 years.
5 years, and zoledronic acid or bisphosphonate also for 5 years.
So with ovarian suppression, you give 5 years.
With ovarian suppression for 5 years.
5 years.
Yes.
So tamoxifen currently, what is the evidence for?
No,
How long?
tamoxifen is proven now with current evidence. Tamoxifen is recommended only for very low risk group where chemotherapy is not indicated. So if a patient is not having any indication for chemotherapy, then that patient is having luminal A, very low risk breast cancer. So those patients, tamoxifen is a reasonable option. And when you give tamoxifen, you can go up to 10 years
10
because tamoxifen is proven for 10 years. Compared to 5 years, 10 years will have some additional benefit. But with aromatase inhibitors, it's 5 years. Current standard is 5 years.
While the patient is on tamoxifen, goes into menopause, would you give like 5 years for tamoxifen, another 5 years of aromatase, or what?
That applies for patients who have started tamoxifen for some reason. And so if the patient is not in very low risk group, then as soon as I see such a patient, I will convert. irrespective of the menopausal status. For example, if the patient is still 45 or 46, still, and if the patient is on tamoxifen, for example, for 1 or 2 years, what I will do is we call it switch therapy. So I change to aromatase inhibitor unless the patient is having very low risk breast cancer. So switch therapy is proven, and converting tamoxifen to aromatase inhibitor will improve the survival. So very low risk group, even if they get into menopause, no need to change them. Because very low risk group, even postmenopausal, tamoxifen is a reasonable option. So it should depend on the risk level and not on the menopausal status. So irrespective of the menopausal status, if the patient is having significant risk and if the patient has had chemotherapy, then definitive treatment, hormonal treatment is aromatase inhibitor, irrespective of the menopausal status. And if the patient is not already menopause, we have to induce the menopause medically.
So how would you follow up this patient now after completing the treatment?
Yes, so breast cancer actually only proven follow-up investigation. So clinical assessment we have to do. So so usually when this sort of a patient who is on hormonal treatment, they will come and see us every 2 to 3 months at least. So clinical assessment we can do every time. And proven follow-up investigation is annual breast imaging. So for below 50, ideal breast imaging would be to do MRI once a year for 5 years during the follow-up.
So 3 monthly clinical examination and yearly mammogram. That is
Yearly mammogram. But nowadays, with the invention of stereotactic radiotherapy for metastatic disease and management of oligometastatic disease, there is a confusion over whether we will be we will require to do imaging, but that is not proven because now early days, if a breast cancer patient gets lung or liver met or even bone met, then it is incurable at that point. But now, if the patient is having only limited number of metastatic lesions, some say it's 3, some say it's 5, but certainly less than 3 metastatic lesions, then we can give ablative treatments, ablative radiotherapy to those metastatic lesions, and then we change the systemic treatment, and portion of patients could be cured by that. So there is a dilemma over whether we should go and aggressively look for metastatic disease before it gets multiple. So because of that reason, there are some protocols where annual imaging is performed, but proven follow-up imaging is only breast imaging, and systemic CT scans will be optional.
Okay, thank you. So now
Breast imaging for 5 years, aggressive breast imaging, and after that population recommendation will apply to them.
Any place for this CDK4/6 inhibitors?
No, CDK4/6 inhibitors are for the recurrences. So adjuvant, initial adjuvant treatments, we don't use them.
okay, so this patient we followed up for 5 years. After 5 years, you detected another lump on the same breast. So what would be the next step in the management?
Yeah, she had already completed one cycle of treatment for the breast cancer. So I hope this is not a new primary, it's a recurrence. So she is already radiated. I think we have to consider a mastectomy in this situation.
So confirm it with biopsy and offer mastectomy for this one. What about the eye?
Yes, current standard is mastectomy because breast is already radiated. As we were discussing now, previous breast irradiation is a contraindication. That is absolute contraindication for breast conservation. And I mean, at that time, actually, the other thing we have forgotten to tell you all is the contraindications for radiotherapy apart from previous irradiation. So generally, we consider uh, uh, contraindications for breast irradiation as radiosensitive syndromes. So certain patients are having increased sensitivity to radiation. So they get a lot of reactions with radiotherapy. So when they get a lot of reactions, the one problem is getting through the radiation is a struggle. And the second problem is now whole aim of breast conservation is to have a better cosmetic outcome. So if the patient gets a serious reaction with breast radiotherapy, then whole breast and skin will get fibrosed at the end of the treatment. So your purpose will not be served. So for those patients, mastectomy and reconstruction would be a better option. And syndromes wise, there are some rare syndromes, but common thing we should consider is rheumatoid arthritis. So patients with rheumatoid arthritis are highly sensitive to radiation side effects. So we avoid breast conservation for rheumatoid arthritis patients.
Dr. Nalin, what are the reconstruction options for this patient?
Yeah, so we have both autologous and implant-based reconstruction. In our country, the autologous is the most common thing for several factors. And if you're going for, I come to implant, if you're going for autologous reconstruction, depending on the breast volume, you can think of doing a abdominal flap or a latissimus dorsi flap like a ELD. The abdominal flap you can do if you have a microscope availability in your hospital, train people to do it, you can do a DIEP. Because you need to know as trainees that DIEP is the gold standard for if you're going for abdominal flap. In hospital, I don't have a microscope for me, so I do a trap. ELD is a good option because you will be harvesting a lot of adipose tissue around the latissimus dorsi, so enhance the volume of the flap. So you can do a ELD flap as well. And if you are going for a implant-based reconstruction, the problem is the cost and the type of implant. Because in Sri Lanka, what we have is only the round implant. We don't have the better anatomical teardrop implant. And these are non-textured implants. In terms of BIA LCL, it is safe. But the problem with the implant is other thing, don't have the mesh to cover the implant. So that patient will invariably have to have a LD muscle rotation as well to cover the implant. So they will have this. We can do implant-based reconstruction in this country. We will be doing implant plus autologous. It invariably boils down to that. So we have done, but only thing because this is a round implant, it don't have a teardrop anatomical shape. Aging, the other side will drop, but this will sit right up. So there will be problems. So if the patient is not concerned, that's fine. There are benefits in doing implant reconstruction. It's supposed to be less time consuming, but in our setup, we are doing rotation the LD muscle as well. So it more or less, it will take at least 4 hours. But in comparison to abdominal flap, it is less time consuming. So these are the options that we have. And sometimes the patients who have had, we are doing for smaller breast, and if they don't have enough tissues in the abdomen, then there's going to be a problem. You will have to have anyway implant plus a LD flap.
Is it possible to do a skin sparing mastectomy in a radiated patient?
Yes, of course, we can do a skin sparing mastectomy. Only thing is you will experience a bit of bleeding. In radiated breast, you will have bleeding, and apart from that, again, you will experience bleeding if the patient has undergone neoadjuvant therapy, not in this case. So radiated breast, we can do a nipple sparing mastectomy and implant. So make sure you are not thinning out. You stick to the anterior lamellar fascia, do a proper tissue plane dissection, because especially around the nipple lateral complex, skin is very thin. So make sure, but you can't, I mean, control the oncological safety. You need to take all the ducts in the nipple as well. So it won't necrose if you do it properly, and make sure you set the diathermy to a lower mode and do a bit of dissection from the scissors and use a bipolar. Yeah, you can safely do that. So it can be done.
So if now for my knowledge, I'm asking this. So if a patient is having even recurrence even upfront, if the patient is having nodal involvement, would you consider nipple, skin sparing mastectomy? Because oncologically, when the nodes are involved, what we think is now, for example, in radiotherapy, we include the skin when the nodes are involved, because we think that subdermal lymphatics will be having minute deposits. So in that context, if the patient, for example, this patient, it's very small recurrence, and if node negative, I am completely fine with the skin sparing mastectomy. But if this patient is having nodes, then would you avoid skin sparing mastectomy, or would you be still happy to do skin sparing? Because if it is upfront, then we will be radiating the skin. But for this patient, we won't be radiating even the skin.
So it can be done if you look at the evidence. I mean, apart from that, if such a patient comes like this, then the only option will be just simple mastectomy, isn't it? It's not so. So you can irradiate. You talk with the patient, give the evidence, and say you can do nipple sparing mastectomy or skin sparing mastectomy. Because I'm saying if there's a recurrences in the skin, you can do a skin reducing mastectomy, right? So it is possible. We can do that. We have done. No, I mean because. Yeah, so you're asking axilla is on now this time. I don't know about the axilla this time. So it was previously axilla is done. Yeah, so still we can do. Yeah, so dermal lymphatic invasion. We talk about dermal lymphatic invasion, especially in inflammatory breast cancer, but still it can be done in this. Yeah, I can't find any evidence. Probably it's there. Yeah, so to say not to do it, it's company. It's nothing like that, and the recurrence after. This sort of scenario, I haven't found.
So node positive breast cancer upfront, it's fine because we will be including the skin in our radiotherapy volume. But here I wonder, I mean, this is a new question for me also. If the same patient was having some nodes somewhere, even after axillary clearance, if some nodes are still positive, then since subdermal lymphatics are possibly having some deposits, and we will not be giving any more radiotherapy to this patient's skin. So in this context, doing skin sparing mastectomy, I mean, I'm not aware of the literature, but cancer biologically, there seems to be some risk of some leftovers with the subdermal tissues.
I get you, but I have a very small number of patients fitting to this scenario itself. It's very minute in any context. But if that is so, I mean, if you get there's a risk of recurrence in the skin. So if you get a recurrence, I think we need to look at the evidence. I'm not aware about this particular scenario with that, but we have done, but they haven't had any recurrence up to now because it's a 5-year period. So we will have to look into that evidence and see.
What would be the adjuvant treatment and follow-up now after the recurrence? Offering chemo again or what?
So now this patient, after completing hormones, is getting only a local recurrence, and systemically I assume that she's
okay.
She's all right. So then for this context, we can go for CDK4/6 inhibitor with the second line hormones. So that is this standard management because this is recurrent breast cancer. And the other option is to give some sort of pseudo-adjuvant sort of chemotherapy, but this is 1 centimeter, very small recurrence. So subjecting this patient for the second course of chemotherapy, it's bit controversial because it's very early recurrence. So I would prefer second line hormones with CDK4/6 inhibitors, but giving second line chemotherapy. So second line chemotherapy, we have options like capecitabine or mineralbine. So giving one such chemotherapy, again, it should be followed up with second line hormones and CDK4/6 inhibitors, or the other option is to go with only CDK4/6 inhibitors. Considering a very small volume recurrence without any regional involvement or systemic involvement. Systemic involvement is anyway different, but without any regional involvement, I would prefer just second line hormones plus CDK4/6 inhibitors, that is palbociclib.
Okay, thank you very much. I think that concludes the first case. I think we have covered most of the breast cancer management in the first case. So shall we have the break and then go for the next one? Now it's the other cases are short, so we have to just to see the differences of it. Do you have any questions from the panel, from the first case?
They can ask.
Yeah, do you have any questions? Then we'll have the break.
Yes.
Sorry. Marks that. We'll wait. Shall we start? Yeah. We're going to the case 2. So this is a 45-year-old nursing officer presented with a lump over the right breast. On examination, there was a 2.5 into 3.5 centimeter lump, 9 o'clock position of the right breast. Axilla is again clinically negative. Mammogram was reported as BIRAT 5 and ultrasound axilla is negative. Histology, it's a triple negative breast cancer. So from the oncologist, so this is a 2.5 into 3.5 centimeter triple negative breast CA. So what's your approach for this patient?
Yeah, so what about nodes?
Nodes negative, clinically negative, axilla is negative.
Yeah, so again, young patient, relatively small breast lump without nodes, but triple negative. So there is definite indication for chemo. So when it comes to triple negative disease, as I said previously, so there is a definite indication for chemo. So that chemo we could give either neoadjuvantly or neoadjuvantly. Benefit will be same. For triple negative disease, giving neoadjuvant chemo will have certain advantages as well as certain disadvantages. So we have to balance it out. So advantages wise, for triple negative breast cancer group is the group with worse outcome. So they tend to do poorly because we have only chemotherapy as the only oncological treatment. Whereas hormone positive cancers, we have hormones. We have palbociclib like cyclin CDK inhibitors. And for HER2 positive cancer, we have trastuzumab and several other HER2 targeted treatments. Here, what we got is only chemotherapy. So, because of the poor outcome, we are trying various strategies to improve the outcome. One such strategy is to offer 2 chemotherapies under the initial treatment for poor responders. And to offer that, we have to give neoadjuvant chemotherapy. For example, if we give neoadjuvant chemotherapy for this patient, and then if the patient goes for surgery, after surgery, depending on the histology report, if there is residual disease, for those patients, we offer another course of chemotherapy. So that means 2 courses of chemotherapy for the chemo responders. But so that is the advantage in offering neoadjuvant chemotherapy because we can assess the response pathologically if we give neoadjuvant. But if we do surgery and then give adjuvant chemotherapy, we will not have any option of assessing the chemotherapy response. The disadvantage side is if we give neoadjuvant chemotherapy and if the patient is having rapidly progressive disease and if the chemotherapy is not responsive, there is a potential of having metastasis during the delay. So micromets can escape from the primary tumor and risk of metastasis could increase. So we have to balance these 2 advantages and disadvantages in our decision making. So for this patient, it looks operable. So having upfront surgery is also not wrong. And giving neoadjuvant chemotherapy followed by chemotherapy is also not wrong. And I will approve both options.
Right. So the patient was taken to MDT and the decision was taken to give neoadjuvant chemotherapy, and neoadjuvant chemotherapy was given. So before neoadjuvant chemotherapy, anything that would suggest from the surgical side to from the radiation?
So I think if you have decided on neoadjuvant, we have to clip the lesions because if she is a complete clinical responder, of course, we wouldn't be able to identify the lesion during the surgery. And also, I would prefer to do sentinel lymph node biopsy upfront. Anyway, because nodes will be negative if it is again complete responder.
So yeah, after clipping the lesion, we have completed neoadjuvant chemotherapy and there was complete clinical response. From the radiology side, would you recommend a repeat mammogram or MRI for complete clinical responder? So
Generally for triple negative, MRI is preferred if you think it has clinically completely responded, because MRI is more sensitive, and particularly it also depends on if MRI is not available, then you can do mammogram special, and if the initial tumor was very nicely seen on mammogram, then you can do. Otherwise, if it was not clearly seen, or if you want to be very specific, very sensitive, then MRI can be done. But MRI is non-specific, can have false positives also.
Dr. Nalind, what is your view about the upfront sentinel node biopsy? Do you do that? Or?
No, we don't do upfront sentinel biopsy. I know there's a practice like that. We do, if the radiological the axilla was negative initially, we do sentinel node biopsy after neoadjuvant chemotherapy. So that is also sensitive. And about the clipping of the node, so the clipping the tumor, either to place a single clip in the center or to clip the tumor margin. What do you think? So routine what is done is to clip the center, right? So in this sort of case where you have complete clinical, and if there's a radiological loss of clinical response, you can identify the clip with ultrasound, the wire, that's fine. So are you going to remove only the clip? It's going to be a clipectomy, not a lumpectomy then, right? So these are the controversies that is going on. If you see the literature, and there's Professor Vaidyachayan from London, he has produced a lot of papers, I would say controversial, but concerning this argument about clipping the lesion in neoadjuvant setting. I mean, he's a bit eccentric, and he's saying not to give neoadjuvant. That's which I don't agree. But these arguments are there. So if there's a complete clinical response, how much are you going to remove? Is it only the clip? So is it the original of the lesion? Then how you can identify that? So if I'm clipping, it's to clip the center, but the margins as well. So for me to have some idea what I'm going to do, but complete the complete response to chemo from these triple negative and HER2 positives, it's very hard to see. It's very hard to see. I mean, most of the time we see at least 40 to 60% cellular remaining in the pathological specimen. Whether it's something to do with the chemotherapy quality that we use, I don't know. These are the practical points which we haven't seen in other countries. Yeah, that would be.
For triple negative, I think pathological complete response rate will be less than 40% certainly. But for HER2 positive, you should be able to achieve 60-70% of complete responses. So that is the standard with HER2 positive breast cancer. These patients, that's what I said actually, while having chemotherapy, certain patients can progress. and can even develop significant rate of metastasis. So that is the disadvantage in giving neoadjuvant chemotherapy. So yeah, when it comes to resection after complete response, what is the purpose of that resection? So one purpose is to see whether there is complete pathological response, because complete clinical response is different from complete pathological response. And for that, actually, we need significant we need at least some quality sampling from the tumor area. Are we aiming at removing the entire initial tumor bed? So we have to think about that aspect. So if we are to remove the entire original tumor bed, then clipping may not be the ideal surrogate to do that. To get a good sample, I think clip should work. So what you should do is, I think at the end of treatment, you can place a wire into the clip, and if the surgeon is taking significant portion of breast around the wire, and if the entire specimen doesn't have tumor, then we can safely conclude that the chemotherapy achieved complete pathological response. And that will be important for our decision making. And even if some microscopic leftovers, I think since we will be giving radiotherapy, those microscopic leftovers will be sterilized with radiotherapy. So I think overall clipping will help, because we will be getting representative sample for logical assessment. And as an oncologist, the most important thing that I will look for in the histologic report of a triple negative patient is the microscopic residual disease. So that purpose will be served by taking a good sample around the clip. And if the clip is placed centrally, then certainly I think you should be able to get a good sample.
Yeah, I agree. I mean, that's what we do. We clip, we put a wire and take the tumor bed. But there are some studies, these are controversies, okay? So arguments. So why do we need to do a surgery then? Can't the radiologist do multiple core biopsies from the area? Well, already the area is clipped. So the tumor bed, you know. So these studies has been there. And it says, okay, you have done core biopsies, it's negative. So then are we happy to agree with that and carry on the rest of the treatment? But there have been some trials has been stopped prematurely because of recurrence. So there are a lot of controversies, but these are the real life situation.
Yes, so when it comes to triple negative disease and HER2 positive disease, so that sort of approach is, I think, seems to be working for HER2 positive. Because HER2 positive breast cancer, for complete responders, the next step in management will be to avoid the surgery completely. So for complete responders, then radiologists can do multiple biopsies and confirm the microscopic complete response. That again is to offer second line HER2 targeted treatments, and radiotherapy can effectively treat the microscopic leftovers in the breast. But when it comes to triple negative disease, all those approaches are likely to fail because of the overall poor prognosis of this group. Because patients tend to get various types of recurrences. Some get local recurrences, some get systemic recurrences. So to prove such a new approach will be more challenging in HER2 positive, triple negative group, because the overall outcome is not so good. So all these will remain as controversies, but oncologically, what oncologists will require is the confirmation of pathological complete response, or to confirm that microscopic residual disease is present.
Yeah. What is the place of specimen mammogram at the time of the operation?
So if you are practicing wide local excision, it's always mandatory to do a specimen mammogram, right? Otherwise, I mean, in my series also, and if you see the world literature, there is always different benefits of specimen mammogram intraoperative, right? So you do the wide local excision, send it to the mammogram for the radiographer to the mammogram of the specimen to see the radial margin. So you need to, after orientation, you need to place clips in the stitches of the orientation, so you can see which margin is which. And if you feel that there's a the margin is very close, you can always get a intraoperative. Same time, you can get a shaving of that in the margin. So it's a must. So I don't think it's safe to do, but I know it's not available. It's not available in the specimen mammogram. The facilities is not available. But then what you tend to do is you take a bigger chunk. Then the idea of wide local is lost. Right? So it's safe to when you all are surgeons, so you are when you're safe. It's safe to do at least if you put a finger over the tumor and take at least 1 centimeter macroscopically to be on the safe side. And you are when you are dissect away from the tumor, don't dig into the tumor. So you will be safe. But if you don't have these specimen mammograms, that's the way forward, right? But gold standard specimen mammogram.
Would you perform sentinel node biopsy axillary clearance after chemotherapy? We have already discussed. So there are two schools of thought. So some certain centers, they do this pre-neoadjuvant sentinel node biopsy.
Yeah.
But there's current evidence to do post-neoadjuvant as well.
Yeah. So, I mean, we all are placed for theater time, so you can't find a theater slot for the same patient twice. So, and apart from, if you see the literature, there is enough and evidence coming up for post-neoadjuvant sentinel node biopsy. We also do that. And sometimes we, on sentinel, we do the target X-ray dissection. And there's a new study in 2023 came a multi-center trial. It's a meta-analysis including 13 trials. So the verdict simply it's there's a place and it's effective to do a sentinel node biopsy after neoadjuvant chemotherapy. The why the controversy, if you have a positive axilla and if you give neoadjuvant chemotherapy, the lymphatics will be fibrosed and the lymph will be redirected and there will be aberrant pathways. This is a problem. So if you are doing sentinel node biopsy, whether it's a true sentinel that you are harvesting, that's the controversy. So that's why we have augmented the sentinel node biopsy after neoadjuvant chemotherapy with targeted X-ray dissection. We click the node that was seen in neoadjuvant therapy and we make sure we harvest the particular node as well. By sending it to a specimen mammogram, we can see the clip node inside. So we know we have taken the proper harvest.
Right. So I think you answered both questions. So pre-neoadjuvant, if the axilla is negative, there's not much debate. So you can straight away go for sentinel node biopsy. But pre-neoadjuvant, if the axilla is positive, is the problem. So you can do the sentinel node biopsy, but with targeted dissection with clipping of the positive nodes and take the clips nodes out while you are doing the sentinel node biopsy. And the accuracy can be increased with dual tracer techniques. So that is the current practice. So yeah, we can, yeah. So this is a triple negative case. Will this, if this is HER2 positive, will it change your management?
Yes,
from the
certainly.
oncologist?
Then it will be neoadjuvant. That is the best approach because giving trastuzumab or anti-HER2 targeted treatments early will improve the survival. So you should find the way to give the trastuzumab treatment, anti-HER2 treatment early as possible. And best way to do is to give that neoadjuvant without even delaying for surgical recovery.
Right. So that concludes the second case. So difference between the first case and the second case, this is a triple negative case. First one is a ERPR positive, HER2 negative case. So mainly we discuss about the neoadjuvant part of the treatment. And if it is HER2 positive also, we are going for neoadjuvant treatment. So that is the main difference we wanted to highlight in this case, right? So case 3. So this is a 52-year-old banker, healthy, and she has gone for a routine mammogram. And it shows a suspicious microcalcification in upper inner quadrant of the right breast. Ultrasound is normal and clinical examination is normal, and she has no risk factors. So from the radiologist side, Dr. Udari, how do you sample this now? So there's no palpable lesion and doesn't show in the ultrasound.
Yeah, so for image guided sampling, basically we have to see it on imaging. It's not seen on ultrasound, which is the preferred mode for the most easiest way of sampling. So in this case, we have to stick to mammography. That is called stereotactic sampling. So there are different ways for doing that. The most popular but expensive method is vacuum assisted biopsy. It's there at in the government sector, NHS also is there. Although the apparatus are quite expensive, we tend to reuse them therefore. So basically what you do is, it's a big 9-gauge needle. We insert the needle and connect it to a vacuum device. And then there's a way we localize first, go to the correct position, insert, and then when you connect to the vacuum circuit, the needle opens and the adjacent breast tissue gets sucked in. And then we cut. And then we rotate, suck again, cut. Like that, 360 degrees you can go. So basically you get number of sucked. They are not there. We don't call them core biopsies, but they are like suction pieces you get. When you put on a dish, you can see on a slide, you see so many little sucked on pieces at the end. So that is very good for sampling microcalcifications.
Right.
The other method is, because the yield is more. And the other method is stereotactic co-biopsy. That can be done, that also can be done on mammography, but this for microcalcification, we are not comfortable doing that because you can miss the microcalcification, especially if it's a small cluster. But co-biopsy can be used for asymmetric densities and small lesions, densities like lesions, architectural distortions, which we can't find on ultrasound. So in this case, vacuum-assisted stereotactic vacuum-assisted biopsy would be the best way to sample.
Would you clip the lesion at the time of
Yeah,
biopsy?
we call them placing markers,
Markers.
right? So again, that's another sad area because markers are again expensive. So expensive. But so we tend not to put markers in our context if the distribution is quite, if it's segmental or a large cluster, obviously we're not going to suck in everything. But there's always the problem of if you suck in all the microcalcification become positive, but how do you locate them? Because calcifications are no longer there in the breast. So depending, we like to put markers, and we do especially if it's a small cluster.
Right. So this is a stereotactic vacuum-assisted core biopsy confirmed it as invasive ductal carcinoma. And what is the surgical management now?
So it's a non-palpable breast lesion. Actually, we have to do the basic other tests, including the investigations to assess the axilla, including the ultrasound scan. And if the ultrasound scan and clinically negative axilla, of course, we can go wire-guided wide local excision of the lesion, provided that the lesion has been clipped or marked beforehand, and sentinel node biopsy.
Right. So the management would be wide local excision, wire-guided wide local excision, and sentinel node biopsy. So, yeah. So here the challenge is identification of the lesion and the biopsy in the lesion because the lesion is not palpable, right? So the rest of the management would be the same. So the case 4. So this is a 31-year-old patient presented with left breast lump noticed 1 month ago, gradually increasing, no nipple discharge or skin changes. She has her mother had breast cancer at the age of 45. An examination, there was a 2.8 centimeter firm irregular lump in the upper outer quadrant of the left breast. No skin changes. There's single mobile level 1 knot, axilla 1.5 centimeter in size. So from the radiology side and from the surgeons, what is the imaging approach in young patients with breast cancer?
Okay, so imaging wise, we start off with generally in our context, if the patient is less than 40 years, we like to start off with ultrasound. Okay. But having said that, now this patient is 31, so the first imaging would be ultrasound of the breast, but that does not mean mammography is contraindicated. Like we can go to mammography if there's a suspicious mass, we can do mammogram. You can do that. So I suppose I answered.
So starting with ultrasound scan,
Yeah.
if there are suspicious lesions, go for the mammogram.
Yeah, we
mammogram
can
as
do
well,
it. Yeah,
right.
we will do that. All right. Oh, so MRI, yes, that's a good question. So we get very few requests for MRI, but we really like to do MRI because, Michelle, especially younger patients, there are two approaches to MRI. One thing is diagnostic, the patient like this, especially if you're thinking of triple negative, where benign lesions, benign looking lesions can turn out to be triple negative breast cancer. It's very rarely triple negative breast cancer, the management and all that we've heard, it's aggressive form of malignancy, a lot of issues. Imaging also, we face a lot of issues because they tend to be, we saw the typical appearance before, the speculated, irregular. In triple negative, they sometimes tend to be round or oval with circumscribed margins, basically mimicking a fibroadenoma. So MRI and their breast density is higher. So these lesions can easily be obscured. So MRI has a place. What is the current practice like in our context? Because we don't get many requests as we would like to see.
Personally, I do MRI for each patient, certainly below 45 I do, even below 50 I do. Why we do like that? Because now these days, significant proportion of patients undergo breast conservation. So that means only the tumor will be removed and rest of the breast immediately after breast conservation we irradiate. So what if a small second cancer is present, which was not detected on preoperative imaging? Then that will be irradiated and that will disappear. And our systemic treatment is guided by immunohistochemistry. So example now, if a patient is having one breast tumor which was removed and if that is triple negative, then we will not be giving any adjuvant hormonal or HER2 targeted treatments. But if the same patient has had a hidden small second cancer, which is for example HER2 positive, then that second tumor is incompletely treated because that will disappear with radiotherapy and HER2 targeted treatment we will not be offering because we don't know whether such a lesion was present even. So because of that reason, for younger patients, because their breast density is, glandularity is more, there can be hidden small second lesions. So before radiotherapy step, at least, ideally before surgery, we have to make sure that there are no synchronous lesions in the breast. Certainly before radiotherapy, I make sure that there are no lesions before I irradiate. Because if I irradiate, then that information will be lost permanently. And that patient will get a recurrence somewhere else most of the time. So MRI is a must for young patients in my view. And also if the breast glandularity is more, in some patients, even after 50, sometimes glandularity is more and mammography will be mostly white. So there can be hidden lesions. So those patients, I do MRI. And for lobular cancers, I prefer to do MRI because the risk of multifocality and multicentricity is more. And when we are giving neoadjuvant treatment, ideally all patients should have a MRI because sometimes there are patients who are having persistent tumors and we think that there is no response. But sometimes that happens with Schiros reaction, fibrotic reaction. So actually tumor may be responding, but we will not observe any response to chemotherapy. So if we don't have a MRI, there is no other way of accurately assessing the chemotherapy response, neoadjuvant chemotherapy response. So falsely, we may change the chemotherapy assuming that patient is not responding just because the lump is palpable and not changing in size. But when we do MRI, with new multi-parametric approaches and dynamic contrast enhancements, and they have different techniques to assess the cellularity. So cellularity will be actually getting less in some of those patients. So reliably assessing the response to neoadjuvant chemotherapy is only possible with MRI. So because of those reasons, in those scenarios, I personally do MRI, and I think MRI is a must on those situations at least.
Thank you. So, Dr. Udat, what are the ultrasound features of malignancy?
So initially we spoke of mammographic features of malignancy. You remember masses, asymmetric densities, microcalcifications, and distortions. So likewise, on ultrasound, there are a set of features. Main thing would be a mass. Then microcalcifications, a lot of time we do not see. However, sometimes we do see, especially introductal ones. We can see with very good quality machines. We can see to some extent, but we don't rely on ultrasound generally for microcalcification detection. Then malignancy can appear as an architectural distortion, especially lobular malignancies. Architectural distortion only without any mass. Then there are ductal changes, can be focally dilated duct with irregular vascular intraductal material. So there are a number of appearances. So if you want to, the main thing is mass. So here there are three. These are the same patients, right? This is the same patient, right? This, yeah. So two images of benign, malignant, and normal. So this is the normal breast sonographic architecture of the breast. You see this echogenic area. This is the fibroglandular tissues, and this hypoechoic parts are the fatty tissues of the breast. And you see this hypoechoic tracts-like areas. These are the ducts. Okay, so I would say image quality-wise, this is a moderately satisfactory image. When you do high-end ultrasonography, you can see better images than this with more anatomy, breast anatomy seen on normal breasts. Then here on this image, you see a lesion here, right? It's well circumscribed, almost round, hypoechoic. We compare to this fatty tissues. It's less, it's darker than fatty tissue, so it's a hypoechoic. This is a mass, right? So this is a small mass, round. This could be a cyst, but we are not having the posterior enhancement. You will see in the radiology report the term called posterior enhancement. The enhancement is not seen here. So if the enhancement was there, I will say it's a cyst. But here in this one, it is a probably benign mass for me, right? I would not say it's straightly benign. But having said that, these are just two images. If you when you know the probe and see, this could be a cyst, right? So malignancy, now this image shows a very ill-defined mass in this one. This is just a distortion, but here you see an ill-defined mass, which is hypoechoic, meaning it is dark in color. And if you switch on Doppler, you will see some vascularity. You look at the margin, its margin is quite irregular as compared to this one, right? And perilesional tissues, there's some peripheral echogenicity. So this is a suspicious lesion, right? This is quite suspicious. Suspicious lesions would be, masses would be irregular, hypoechoic. They're taller than wide, not crossing the parallel lines, going down, and with vascularity. So those are the basic features. Yeah.
So MRI confirmed that as a multifocal breast cancer. Histology, again, triple negative cancer. So from the surgical side and from the oncologist, what are the key management considerations in young patients with breast cancer?
This is 31 years.
Yeah.
31 years, multifocal, triple negative. So even multifocal actually, so their main concern is whether breast conservation is possible or not because of the cosmetic outcome, or if not possible, then reconstruction options. So that is the surgical aspect, and she will again require chemotherapy. So again, triple negative patient, the chemotherapy will be required, and you can offer it either neoadjuvantly or adjuvantly. And genetic counseling, so that is bit of a controversial area, because now these patients, they can have BRCA mutation and also some other genetic cancer syndromes. So this is very young breast cancer at 31 years. So even there are some P53 mutation harboring breast cancers also, other syndromes, Li-Fraumeni syndrome. So this can be a syndrome, and doing genetic counseling, I would say, would help the family members more than the patient. Because patient's breast cancer, now we have to treat anyway. Breast cancer is already breast cancer is there. So genetic counseling, we have to first tell the options of treatment in case a genetic mutation is found, because there are very, very radical exotic type managements available like bilateral prophylactic mastectomy. So for a young patient, young family member, that will not be the most easy management to convince. When they don't have a cancer at that time, people generally will get shocked when we say such options. So one option is to do the genetic counseling and know whether the genetic mutation is there, and then offering the mutation testing for the family member and going for the breast screening, aggressive screening. And second option is to go for screening as per genetically familial syndrome without offering genetic mutations. And third option would be to offer prophylactic options, and that will be a very difficult scenario and difficult to justify such treatments purely for the preventive purpose. So those will be the three approaches that we have to think.
Yeah, Dr. Nalindo,
Yeah.
would you offer oophorectomy for BRCA?
This patient particular say, so genetic testing is mandatory. We have to talk to the patient. She's 31. Mom also had breast cancer less
Yeah.
than 50 years. So it's mandatory. It alters her management as well, because if she's positive, then we can't do a breast conservative surgery. She's invariably going to develop breast cancer. So we have to offer, if she's positive, some sort of conservative mastectomy to the ipsilateral breast, and later a prophylactic mastectomy to the other side. And with this BRCA1, we have to think of offering prophylactic oophorectomy in the next few months. It alters her management, but it is like opening a Pandora's box. So the entire family will be have to face the reality. So if the index patient is positive, if she has siblings, they will also have to have, we can't advise, they can be counseled to check it. For example, if the index patient has a younger sister who is now 20, she doesn't have to undergo prophylactic mastectomy now. No. So if she also, we can check, even if she is positive, she can under active surveillance, she can have to go on, have a family life, have children. Later, once the family is completed, she can undergo prophylactic mastectomy, because invariably she will also develop breast cancer if it is gene positive. But yes, gene testing is a must, and we have done that. But I have to tell you, gene positive breast cancer is not the majority. It's less than 5% in our setup, as well as in other countries. It's a minority, right? It's not a 95%, it's sporadic.
I tend to little bit disagree with Nalinda. For discussion purpose, we'll have that concern. So this patient, now assume this patient is BRCA positive. So she is already having one breast cancer. As Nalinda said, there is always a risk of second cancer. But when it comes to this patient's outcome, as an oncologist, I would say that the already developed cancer will determine her outcome and the second cancer. So I don't really think that breast conservation is an absolute contraindication for genetic familial breast cancer, because we are mostly worried about the existing cancer more than the second cancer in the future. So I would still happy to offer breast conservation followed by radiotherapy and aggressive follow-up, because we will be doing annual MRI bilateral breast for this patient anyway. And if the second cancer comes in the same breast, anyway, it will be mastectomy at that point. And if she develops another breast cancer on opposite side, we will have the option of conserving that breast also. At that time, the threshold for breast conservation will be, I would say, lower, because we might go for mastectomy because already she developed the second cancer. But at this point, I am happy to offer breast conservation and radiotherapy and follow-up, because I think this patient's outcome will be determined by the triple negative breast cancer that is already there, rather than the second cancer.
Yeah, what is your opinion regarding oophorectomy then?
Oophorectomy for triple negative, I will not offer, because even, I mean, oophorectomy will be entirely prophylactic, because this patient is having triple negative breast cancer. If this patient's breast cancer is ERPR positive, she will anyway require hormonal treatment. So at least medical oophorectomy for 5 years, medical oophorectomy with goserelin will be offered. But this patient's oophorectomy will aim at preventing a second cancer. So that is, I mean, that is similar to the treatment that treatment or prophylactic options that we will be offering for the family members, because that is not a part of the management of current breast cancer, because current breast cancer has nothing to do with hormones. It's a triple negative cancer. So,
But won't it change the overall outcome of the patient
it will reduce the risk of second breast cancer, certainly.
and ovarian cancer as well? Isn't it?
Ovarian cancer risk, I mean, that is risk is for entire peritoneum. So when the BRCA mutation is there, then doing oophorectomy will reduce the ovarian cancer risk by some proportion, but still they develop peritoneal cancers. And they have, I mean, these are autosomal dominant diseases. I mean, I'm somewhat poor in genetics, but there is thing called reduced penetrance or something, because everyone will not develop all the cancers. I think breast cancer risk is around 70% for BRCA1. So 30% will not develop. Ovarian cancer, BRCA1 may be about 50%, but BRCA2, it's less. So doing oophorectomy will reduce the risk of ovarian cancer in ovaries, but they still will get peritoneal cancers. If they are to develop ovarian cancer, then they will get it in the peritoneum, because peritoneum is also having the similar epithelium. So again, that is prophylactic option. So that advice will come for the prevention part, not for the treatment part of this breast cancer. And that same advice or same options will be given for family members also. Prophylactic oophorectomy and prophylactic mastectomy. So I think I will give the decision to the patient, and if she prefers to save her breast and preserve her breast, I see that as a safe option. What do you think, Dilip?
I mean, there are arguments for both sides, isn't it?
I also agree with Mahindra. Breast conservation is an option here. But if she's scared of breast conservation, of course, you can go for reconstruction.
Right. Shall we move on to the next case? Yeah.
So this is a 41-year-old patient presented with a painless, rapidly enlarging lump in the right breast over 3 months. It's about 6 centimeters in size, no nipple discharge, skin changes, or axial lumps. Clinical examination, there was a firm, mobile, non-tender mass occupying the upper outer quadrant of the breast. And ultrasound showed 6 into 5 centimeter well circumscribed heteroechoic lesion with internal cleft and increased vascularity. BIRAD 4A. Core biopsy suggestive of phylloides tumor with intermediate features. So what are the clinical features which differentiate phylloides tumor from a fibroadenoma from this?
Phylloides
Then-
tumor, usually they are very large tumors at presentation. The fibroadenomas are tiny ones, but still you can have giant fibroadenomas. So clinically, they are having distinct margins compared to breast cancers. And the main thing I see is they are huge. Sometimes the entire breast is replaced with the tumor at the presentation. So compared to the fibroadenomas, actually, I think mainly the size is the difference rather than anything else.
Yeah, it's very difficult to differentiate. Mostly size is in it. Right. So ultrasonically or imaging wise, is there any difference?
Yeah, ultrasound wise is same. It's like on one end you have a typical fibroadenoma, which is, parallel, growing parallel to the chest wall, oval shaped, well circumscribed, hypoechoic, but with homogeneous internal echoes, the typical pattern. And on the other spectrum, you have the irregular, hypoechoic, taller than wide, aggressive looking malignancy. So the phylloides would fall some imaging wise for us to suspect it would be somewhere in the middle. One of the main concerns or some of the main things that we look at is the size. If a probable fibroadenoma were looking bigger than 3 centimeters, we tend to think of phylloids. The margins, like they're not typically smooth and oval shaped structure. They're more lobulated structures. Sometimes can be irregular also. So that is the appearance, and it's a challenge, especially to differentiate between. I think it's difficult to differentiate between a giant fibroadenoma and a phylloids, unless it is very large.
So Dr. Priyanka, what are the different types of phylloides tumor and what are the features which suggest of malignant potential?
Yeah, phylloides is a very interesting tumor. Now, previously we were talking about carcinomas, which are basically epithelial tumors. Now, phylloides is a biphasic tumor. That means there's an epithelial component as well as a stromal component. Now, here the epithelial component proliferates, but it's benign. So your carcinomas, it's the epithelial component that's becoming malignant. But here, the epithelial component is benign, but the stroma, which is around the ducts, are proliferating, and that's the malignant component. So basically, the type of phylloides tumor, there are 3 types: benign phylloides, borderline phylloides tumor, and malignant phylloides tumor. So, so how do you differentiate from each other? Now, in the new WHO classification, there's a table giving different criteria separating each and every category. Mainly, basically benign and borderline, as both surgeons and the radiologists mentioned, they tend to be more well circumscribed. And even under the microscope, they tend to be quite well circumscribed. But in the malignant category, you tend to go more infiltrative type of borders. So that's what the others also can see. But under the microscope, we can see that this leaf-like architecture compared to fibroadenoma, more leaf-like architecture in the tumor, and the stroma is more expanded, which is called stromal overgrowth. Is a feature of malignancy. So that's not benign and borderline, the borderline to some extent, but malignant stromal overgrowth is prominent. So what do you mean by stromal overgrowth? Under low power view, in the microscope, we are not seeing any epithelial elements at all. That is under the 40 magnification, no epithelial element in a low power field. So that means everything is stroma. So it has expanded. So stromal overgrowth is a feature. Stromal diffuse nuclei atypia. So nuclei look very abnormal and more stromal cellularity. And mitotic count is a feature. Again, 10 high power fields or 2 millimeters square, you in malignant category, they get a count more than 10 mitosis per high power, 10 high power fields. So benign less than 4, intermediate between 4 and 10, like that. So there are so many features. So all these features should be there to classify it as malignant. So not one feature, but there's one feature, if that's there, that you can straight away call it malignant, that is heterologous elements. So if there's a heterologous osteosarcoma, heterologous chondrosarcoma, or a rhabdomyosarcoma, but not liposarcoma. Liposarcoma is not considered, but all those heterologous malignancies, if it's there, it's definitely malignant. So those are the features that we use to classify benign, borderline, and malignant. Borderline category is a bit of a gray zone, but so in a bigger specimen, this is easy to do rather than a core biopsy. So to your last question, core biopsy, is it reliable distinguishing phylloids from cellular fibroadenoma? I would say it can be problematic. So fibroadenoma also has a similar look to benign phylloides, but the difference is that you see more cellular, like, the stroma is more expanded, and not a lot of nucleatypia, minimal nucleatypia. So in some cases, in core biopsy, we tend to do, if you're not 100% confident, because in core biopsy, you get tiny little bits of tissue from the cores. So what we tend to do there is, you might get reports like cellular fibroepithelial lesion. So it can be a fibroadenoma, it can be a benign phylloides, but I'm not confident. So in that setting, it's called a now, there are B categories in the biopsy reports, which I forgot to mention before. Like if you come across cases, there are, like in the BIRADS, when we report a core biopsy, there are B categories. So for cellular fibroepithelial lesion becomes under B3 category. So B1, B2, B3, B4, B5. B5 is a malignant category. B5B is malignant. B5A is DCIS. B4 is suspicious. B3 is more gray zone, uncertain malignant potential area. B2 benign. B1 is normal tissue. So, so B3 is the cellular fibroepithelial lesion when we are not confident on the core biopsy. So what I would do then is to suggest excision, preferably with a clear margin, because I'm not sure whether it's a fibroadenoma, because there are some features which, because even in fibroadenomas, bit of here and there, you can get some cellular expansion. So that would be the approach in such setting.
Do you recommend any immunohistochemistry for this?
Immunohistochemistry would not be helpful in normal, benign phylloides tumor. It's just a morphological diagnosis. But I would recommend it if it's a malignant phylloides tumor. Malignant phylloides tumor, it's a spindle cell tumor. So my differential diagnosis come into metaplastic carcinomas and other fibromatosis, all those come into differential diagnosis. Then your immunohistochemistry with PAN-CK, P63, CD34 might come into play. And then I have the concern whether it can be, I'm sure it's malignant, but I'm not sure whether it's another spindle cell tumor. That's my concern. But ER2 we don't do for phylloids, so that's not indicated. So yeah, so those are not, and molecular, yes, third promoter mutations has been reported to differentiate, it has been helpful to differentiate fibroadenomas from benign phylloides tumor in studies, but it is not used practically for that differentiation, but otherwise nothing, yeah. So what are the predictors of recurrence in histopathology? I would say margin assessment is important. So, benign, borderline, malignant, we have to give how far it is from the closest margin. If it's not oriented, at least the closest radial margin, we have to go how far when in the excision specimen. So if it's inadequately excised, it tends to recur. So higher rate of recurrence has been reported in malignant phylloides, not so much in the benign, but after a few years and borderline intermediate, like even malignancy, it's around 30% recurrence. And the other things is as I said, benign, borderline. So the type of phylloides tumor matters for recurrence. And it's also related to size. So bigger the size, higher rate of recurrence. So yeah, that would.
Okay, thank you. So from the surgeons, what would be the surgical approach for this patient? Would you offer lumpectomy or mastectomy for phylloids?
So if the genes are negative, I will certainly offer a breast conservative surgery. And the nodes were,
Nodes are negative. Fine.
so, and a sentinel node biopsy. Yeah.
For phylloids, would you do sentinel or?
So it's the phylloids. So if it is phylloids, there's no place for nodal biopsy. But already if you're doing mastectomy, I will do sentinel node biopsy if there's an invasive focus. Otherwise, we will be missing that. For intermediate, so with a wider margin, but for benign, just a lumpectomy.
What would be the margins for phylloids?
Phylloid is malignant, there's it's about at 1 centimeter.
centimeter.
Yeah.
Benign this.
Benign, just like a fibroadenoma can excise. The recurrence rates are, the benign is less than 5%, intermediate about 8 to 10%, but then the malignant it's more than 25%.
So yeah. So sentinel node biopsy is axial clearance is not indicated. We have mentioned that. And the recurrence risk also he has mentioned. So how do you follow up these patients? Is there any particular?
Yeah, so just like if there are more than 40, I will do a mammogram annually, ultrasound scan. That's how we do. And MRI, if you are not sure, there's a breast is very glandular, we think of doing MRI.
Okay, thanks. So I think we have another 30 minutes, is it? Oh, 20 minutes. Huh?
And for phylloids also, we give adjuvant radiotherapy if it is malignant,
Okay,
but not for benign.
right. So this is a 34-year-old patient, 22 weeks pregnant, presented with left breast lump, noticed 1 month ago, increasing in size. Clinically, there was 3.5 centimeter firm irregular lump in the upper inner quadrant. No skin changes, no axillary node palpable. So, Dr. Udari, what are the safe imaging modalities in pregnancy?
Yeah, so we start with ultrasound. We do ultrasound. And then mammography. Mammography is not contraindicated in pregnancy. It can be done.
At any trimester?
Any trimester it can be done, where we do it with shielding.
Yeah.
Um,
So ultrasound is the first line,
Yeah.
mammography with shielding
Is
suspected cases.
is suspicious, yeah. And
So-
MRI,
Yes,
is
what is the
what's
place
there.
of it?
yes, generally, MRI is not, MRI breast is currently it's a dynamic contrast enhanced study. So the issue is not the sound,
Mm.
it's not the magnetic field. It is the contrast
Contrast.
media because gadolinium crosses the placenta and gets deposited and can cause neurotoxicity. So that's concern about dynamic contrast enhanced MRI in pregnancy. ICR recommends against using MRI. Having said that, some European countries, they do. So in our practice, we do.
Generally not
Yeah,
recommended.
Not recommended.
Because so imaging ultrasound scan showed 3.8 centimeter irregular hypoechoic lesion with posterior shadowing, classified as BIRADS 5. Mammogram was not performed at that time. And it was confirmed as invasive ductal carcinoma grade 2, ERPR positive, HER2 negative. Fetal well-being scan is normal at 20 weeks. from the surgeons, what are your key considerations in managing breast cancer during pregnancy? What are your concerns?
The main consideration is the testosterone, the POA. So if in the first trimester, that's a question if you do a breast constitutive surgery because you will be delaying radiotherapy, and if the patient needs chemotherapy, we can't give chemotherapy in the first trimester. So that's one thing, the parity, sorry, the POA. Then the other thing is the how long we are going to delay the radiotherapy. If the patient is going to have anyway chemotherapy, we can wait for radiotherapy because after finishing the chemotherapy, we will be giving radiation. So other thing is the type of the tumor, the immunohistochemistry pattern, whether they need neoadjuvant chemotherapy before that. So these are the concerns that I have. And we have to be very certain about the contractile breast, whether it doesn't have any sinister lesions.
Yeah. What is the safety for this operation in second trimester?
Second time is very safe, so you can give even chemotherapy also. We can do a breast conservative surgery under general anesthesia, but there's always risk that there will be a the unnecessary delivery during general anesthesia. So the anesthetists are concerned, but it's safe. It's generally safe. We can do a breast conservative surgery.
So breast conservation or mastectomy can be offered in second
Yeah.
trimester and
Yeah,
third
yeah.
trimester. Yes. So what is the place?
Breast conservation, you have two methods, blue dye and radio
Sentinel.
sulfur colloid.
Sentinel node.
Sentinel node, yeah. So which, I mean, if you are going for sentinel node, would you do sentinel node during pregnancy? And which option will you do?
For sentinel node, if you are doing is a negative axilla on ultrasound scan, so the radiotracing is safer than the blue dye. All blue dyes, it's methylene blue or the patent 5 blue, whatever blue dye, it's not safe. But it's safe. Second trimester node is safe. So if you are, unless you are doing in the first trimester, you have to always go with the radioactive tracer. But if you don't have a radioactive tracer, don't give blue dye because it's not advised, it's not safer. Then you might think of doing X-ray sampling. Yeah, we can do give blue dye in the second trimester, but not in the first trimester.
And one question for trainees benefit and also for my knowledge, I will ask from Udari. So now MRI with gadolinium is not recommended because of the contrast. But as an oncologist, for example, if I want to assess the initial accurate tumor size, and if the patient is young and mammogram is not conclusive, would you be happy to do an non-contrast MRI? Just to get the tumor size, because malignancy will be confirmed by biopsy. So you don't have to comment about malignancy on MRI by doing contrast studies. So would you be happy to do a non-contrast MRI to assess the size of the lesion?
There is a place because there is this sequence called diffusion weighted imaging, DWI. So that has the ability to show tumor. It's like when you put all the facilities together, you give a good report. But we can give some report, but I will not be happy. Yeah, but yes, if you want to know specifically the size, we should be able to tell if on grayscale imaging, that is non-contrast imaging, if the tumor is a different color than the background breast, because there'll be a lot of glandular tissue, especially with pregnancy. So if it's a different intensity, yes, we should be able to tell, but there is no guarantee on that.
No, I asked that because size is one very important parameter in management decision making. So if, for example, if we are giving neoadjuvant chemotherapy, so if the surgery is done upfront, then we will get the size information from the histology. If we are giving neoadjuvant chemotherapy, then we will not, we will never know the size of the tumor unless we do some sort of accurate imaging. And if a mammogram is not clear, that is quite likely during pregnancy because of the glandularity of the breast. So in that context, that's why I asked that question. So you are not entirely happy to do that. Yeah. And for trainees, benefit, yeah, for trainees actually nowadays with modern management of cancer, the important thing that you should know with a pregnant patient with any cancer is actually we always try to save the baby or fetus. So that is the main feature in management of any cancer during pregnancy. So we do therapeutic terminations very rarely these days. And that again is for cancers like leukemias and certain hematological cancers where immediate chemotherapy is required in first trimester. And with such chemotherapy, actually carrying a pregnancy is also difficult even during second, third trimester if a patient is diagnosed with leukemia. So those are the, practically those are the only indications to offer therapeutic termination. And in any other patient, we will find some other way of managing the pregnancy as well as the cancer. So we try to deliver a healthy baby at the same time while treating the cancer. And we can't offer the protocol-based treatment always. So there will be certain modifications, but certain modifications, which are minor modifications, will have enough evidence to follow now, because there are a lot of case series and a lot of case reports where healthy babies are delivered with slightly modified treatment approach. So in principle, first trimester, you avoid all cancer treatments, and surgery also you avoid unless it is mandatory. So second trimester onwards, basically most solid cancers we can give even chemotherapy. And when it comes to breast cancer, hormonal treatment is contraindicated, radiotherapy is contraindicated, chemotherapy we can give. And if the patient is having HER2 positive tumor, anti-HER2 treatments are also relatively contraindicated during the pregnancy, because those treatments can cause either usually oligohydramnios, but sometimes polyhydramnios. But if the benefit is much overweighing the risk of oligohydramnios, still we can give anti-HER2 treatments, but we don't give hormonal treatments during pregnancy, and we never give radiotherapy during pregnancy. And if the patient comes early in pregnancy and if breast conservation is possible, but if we are worried about delaying having radiotherapy, still we can explain that delay to the patient, because breast cancer is not a very rapidly proliferating tumor compared to some other cancers. So radiotherapy delay, impact of radiotherapy is not that much compared to certain other cancers like squamous cell carcinomas. It's not advisable in normal circumstances, but if the patient wishes to save the baby, and anyway we can't terminate for such a minor indication, so we all have to accept such a delay and the impact of that delay, because it's not very significant. And usually what we do is we complete the surgical treatment, and as soon as the baby is delivered, we offer radiotherapy.
So how would you plan the delivery? How you with the treatment, and what is the timing of the delivery? What are your concerns?
So if this patient, for example, this patient is having operable cancer, isn't
Yeah.
it? So once the surgery is done, so it's 22 weeks. So assume that immediate surgery was done, then earliest possible delivery time is around 32 to 34 weeks. That is where lung maturity comes. But always we try to go up to 35 plus 30, 36, 36, no, if not 37, at least 35, 36 weeks to allow more maturity. And in this patient, if no nodes are positive or if no other indications come up for chemotherapy, the patient will not be getting any treatment for that period, 22 weeks onwards up to delivery. So that is the only concern if we are not offering adjuvant chemotherapy.
In case if you are giving chemotherapy,
If we are giving chemotherapy, the decision making will be much easier, because chemotherapy we can give during pregnancy and it's safe. So we can, after surgery, we can start chemotherapy, and during chemotherapy, we don't expect any fetal malformations or mutations or any other problems. The main concern is IUGR. So we will ask the obstetrician to do frequent Dopplers when a patient is on chemotherapy. So around 26, 28 weeks, we start doing frequent Dopplers. And if there is IUGR, we advise immediate delivery. And for lung maturation, steroid injections, something they give, make the lung maturity faster. So we plan to go up to 35, 36 weeks, and we stop chemotherapy at 34 weeks. And after that, remaining chemo we give after delivery, and usually if no IUGR, then the pregnancy can go up to 36, even 37 weeks.
So
And delivery will be with cesarean section, not a normal delivery. So
then you're expecting about 4 weeks gap for the
from the last chemo,
Last
last chemo to the delivery.
delivery.
And at any point, if there is IUGR or if immediate delivery is required, we should be ready. So we have to give steroid injections around 28, 30 weeks to make the lung maturity faster. And if we are not giving anything, then there will be a difficult question of whether to 36, 37 weeks, because then there will be 15-week gap in the surgery to next treatment, because we can't give hormones, we can't give radiotherapy. So I am more concerned about hormones, which is the systemic treatment here. Radiotherapy delay, of course, that aims at local control. So even if there is a local recurrence, you can always offer another surgery. But I am more worried about systemic control. So in that context, maybe I would go for 34, 35-week delivery if we are not giving anything.
From the pathologist, is there a difference in tumor biology in pregnancy here? Tend to be more aggressive?
Yes, pregnancy-associated breast cancers are aggressive tumors. So most of these tumors are grade 3 tumors, most of the ones. When you grade it, and hormone receptor wise also most of them tend to be triple negative, some tend to be HER2 positive. So, and also they tend to be larger tumors. So mainly, and also higher stage by the time they present. Maybe it's late, some say it's due to late presentation, because in pregnancy there are breast tenderness, breast engorgement. So all that leads to even during postpartum period lactating breast. So people won't think that they're having a malignancy and they need to present late. So basically higher stage, bigger tumors, and high grade and aggressive tumors in pregnancy.
I think
So
you have
just
answered more.
one question. Actually, compared to age-matched group of other breast cancer patients, do you still think that pregnancy-associated breast cancer is more aggressive and
Yes, in the studies, like in the studies now, even though it's late presentations and younger patients, even in the same age, the pregnancy-associated tumors tend to be more aggressive. They tend to be more aggressive according to literature. I mean, what I have seen also, pregnancy ones are basically grade 3. I mean, I don't know the follow-up, but usually what we see morphologically tend to be more aggressive tumors, larger.
and some explanation is actually the relative state of immune deficiency during pregnancy. So they can get more aggressive because patient's own immunity is not optimum compared to a even age-matched young breast cancer patient. And detection also will be late because there will be masking things during pregnancy with the breast enlargements anyway, even during normal pregnancy.
Right. I think that concludes the last case. We are left with another case. I think time has come, right? So we'll give some time for the trainees to ask any questions from the panel. Anything to clarify?
uh, surgery has been done. What indications for chemotherapy after completing both neoadjuvant and surgery?
Yeah, as we discussed initially, so giving chemotherapy neoadjuvant and adjuvant will be same. So either you give chemotherapy neoadjuvantly or adjuvantly in most cases. So now if we divide the breast cancer population into three groups, then ER, PR positive, HER2 negative group, even if there is residual disease, we will not be offering any adjuvant chemotherapy because patient will be starting on hormones. After neoadjuvant and surgery, patient will be given hormonal treatment. And when it comes to HER2 positive breast cancer, and if we had given neoadjuvant chemotherapy, and if the patient is usually anti-HER2 treatment is given for 1 year, but we do surgery at the completion of 6 cycles. So initial 6 cycles, we combine anti-HER2 treatment with traditional chemotherapy. And then when the surgery is done and if the histology is showing complete response, what we do is we continue the same anti-HER2 treatment for 1 year. But if the patient is having residual tumor, then again there won't be any conventional chemotherapy, but we will change the anti-HER2 treatment. So anti-HER2, there are different treatment options. So usually we start with trastuzumab or trastuzumab along with pertuzumab if that is very expensive and not supplied free of charge from government. So if the patient can afford, we can start a dual anti-HER2 treatment upfront. And if the patient is still having microscopic residual disease, we convert to a treatment called trastuzumab emtansine, another targeted treatment then that has a structure where antibody is combined with the chemotherapy part. So locally chemotherapy effect will be there, but we will not be giving any systemic chemotherapy again in HER2 group. But triple negative group, if we had given neoadjuvant chemotherapy, and if the histology shows residual microscopic disease, then we will give another line of chemotherapy that is capecitabine. So standard treatment is capecitabine chemotherapy for 6 months because we don't have any targeted option in that group because they are triple negative. So other two groups, the targeted treatment only, microscopic residual disease, but in triple negative group, you give chemotherapy.
Thank you, sir.
Any more questions? He's asking for recurrent phyllodes.
Phyllodes tumor. So what are the options? Re-excision or the mastectomy would be the.
So recurrent phyllodes after breast conservation.
Yes, sir. After lumpectomy.
Yeah, so recurrent phylloid is if you have done a previous wide local excision, still there's a place for wide local excision, depending on the size of the recurrence and the site. But if it is, if you think the margins cannot be achieved, then you will think of have a discussion with the patient for a mastectomy. But there is a place for wide local re-excision.
Thanks, sir.
Upper inner quadrant tumors, there's a problem that we think some of the lymphatics drain into the internal memory nodes. So in radiation, we hope that the oncologist will irradiate that chain as well. I think Myla will agree with me.
So inner quadrant tumors also majority is draining to axilla. So when it comes to radiotherapy, unless now one scenario can come up, I think when you give blue dye or radio tracer, if the surgeon reports that the I don't know whether you can tell whether the dye is going to internal memory. You can't see, but if they don't see proper drainage or can't identify the draining lymph node, then sometimes we consider giving radiotherapy to internal memory. The other scenario to give internal memory radiotherapy is if a patient is having extensive involvement of lymph nodes. For example, maybe 10, 15 nodes are positive, then always there will be retrograde spread, even for a lateral quadrant tumors. So for such patients also we give internal memory radiation. But routinely we don't offer internal memory radiation. That is with a reason, because whenever we give internal memory radiation, we struggle to keep the cardiac dose within the tolerance level, because we have to get into mediastinum to offer radiotherapy to internal memory chain. So internal memory radiotherapy we offer only for very selected patients. Just because the tumor is in inner quadrant, we don't routinely offer. And in case if such a patient gets isolated internal memory relapse, then still we can salvage that sort of patient with radiotherapy to internal memory nodes after initial treatment. So that is the rationale to not to offer, because if we try to offer internal memory radiation to all inner quadrant tumors, the problem associated with that will be, then there will be increased cardiac dose and there will be deaths associated with ischemic heart disease in late follow-up.
Normally, for high-grade tumors, you give anastrozole inhibitors with ovarian suppression. If a young patient comes with like a 30-year-old come with high-grade tumor, and he has to complete the family as well as fertility wishes, do we still go for AIs or start on tamoxifen, or what are the options?
No, we go for high-risk patients. So younger patients are the ones with high-risk disease usually. So we always go with ovarian suppression, but ovarian suppression is for 5 years. So for a 30-year-old patient, then she can probably get her fertility back after 5 years. Even while on tamoxifen, they can't get pregnant, because if they get pregnant, we have to stop tamoxifen. So during next 5 years, anyway, even if we are giving tamoxifen for very low risk young patient, still we have to advise for proper contraception, because they can't get pregnant. Because if they get pregnant, then adjuvant 5-year treatment will be interrupted and recurrence rate will get.
So, patient come with a breast lump where the histology comes lobular carcinoma. What is the surgery we are doing? Is it a excision biopsy or a white local excision?
Lobular carcinoma in situ, it's not regarded as a malignancy now, right? So it's like a benign entity. So although it says LCIS, it's not does go in hand in that DCIS. So you might find LCIS in a excised specimen, but not in isolation, right? So the risk is very low, right? You don't do even a lumpectomy, and you don't get LCIS specimens to say LCIS, right? In a core biopsy. I haven't seen.
I'll add on to that. There are 3 types of LCIS. One is classic LCIS, but there's a pleomorphic LCIS and florid LCIS, which are more aggressive. So in that setting, you might, it's considered as DCIS, I think, yeah. So, but for most of the time, it's classic LCIS, and it's only a risk factor. So you don't do basically worry about it.
Any questions, sir? Anyone?
She said what's a lump? Biopsy given as LCIS, but we are not sure whether there's an invasive component is there. So if there's any place for an excision biopsy there.
Can do another core. If your first core says only LCIS, doesn't say fluoride or classic, then you can go for another core biopsy. If two core biopsies are negative, discuss in the MDT, go for a excision biopsy. Right? And if before that, if you have MRI facilities, do MRI.
So another question. Suppose have a malignant glioblastoma, you consider going for a mastectomy, sir? Some size and.
Yeah, the size and you discuss in the MDT, if it is, sometimes these sarcomas are enormous, right? So I don't know whether we have any sarcoma MDTs, but there are, we discuss in the NDT, if it is so, you do if the MRI and it's done, so you go for upfront neoadjuvant chemotherapy or a mastectomy.
Mostly you do mastectomies when you can't achieve a proper cosmetic outcome in phylloids. Otherwise, it's mostly wide local excision.
That is the practical situation in
Yeah.
most malignant.
Yeah, it becomes very big and sometimes the cosmetic outcome is not very good. In that case, you may go ahead with a mastectomy. Otherwise, it's always wide local excision. Okay. In the absence of more questions, we can conclude the session. I think we thank all the panel members for participating in this occasion. Okay, that's.